Good evening, all. Today we will move to day 7 of our review course session. So today we will have our first topic on antimicrobials and antifungals. So I would like to invite Dr. Rohit Patnaik sir, Associate Professor from Department of Critical Care, to please start the session. Sir, over to you.
Hello everyone. Today's topic
The voice is audible, na?
Yes, sir.
of mine is antimicrobials and antifungals. So when we approach any exam question in theory or in practicals in Viva for antimicrobials and antifungals, we have to discuss these antimicrobials with respect to these particular sets of things. It's better to describe in this manner. It will fetch you the maximum amount of marks. It might be only for it might be only for theory or even for practical. You have to speak of class of drug, spectrum of activity, mechanism of action, administration, specifications, that is the various formulations, the metabolism, the organ-specific dosage adjustments, any adverse effects, drug interactions, and how to monitor the activity of this antimicrobial and anything specific to that particular antimicrobial and the site of infection or penetration of the antimicrobial. So this is the best way to describe any particular antimicrobial or antibiotic or antifungal agent. So what I will be doing is I will be giving you a brief of mainly the beta-lactam antibiotics along with the BLBL, the beta-lactamase inhibitor antibiotics, and I will be talking. I will not be dealing a great deal into the several classes of antibiotics which are there. This is just a brief overview and an idea as to how to write in theory exams and how to approach practical vivas. So beta-lactam antibiotics. So basically, it is a beta-lactam antibiotic consists of a core of a beta-lactam ring, which is a four-membered ring. And this modification of this basic structure has led to various antibacterial compounds. And these compounds include penicillins, cephalosporins, carbapenems, and monobactams. So these are the four classes of beta-lactam antibiotics. They will definitely be asking you the classes of antibiotics in beta-lactam antibiotics. So coming first to the penicillins, if you see here, this is the first class, that is the penicillins. So all penicillins have this particular beta-lactam ring here. Obviously, this is one beta-lactam ring, and they also have a thiazolidine ring, and they have a variable side chain. So basically, this is what is the structure of a basic penicillin. And if you have a hydrolysis of the beta-lactam ring by beta-lactamases, that is bacteria producing beta-lactamases, it yields penicillinic acid, and this penicillinic acid lacks antibacterial activity. So this is how the genesis of the beta-lactamases and how they act on the beta-lactam antibiotics comes from. So I told you that the beta-lactam ring is the core of all the beta-lactam antibiotics, and thus beta-lactamases will act on the beta-lactam ring and hydrolyze the beta-lactam ring, and this will lead to reduction to the lack of antibacterial activity in beta-lactam antibiotics. So what about the classification? So based on the 6-aminopenicillinic acid moiety, this will determine the pharmacologic and antibacterial properties of the various resulting molecules. So if you see, the penicillins are actually divided into various types: the natural penicillins, the anti-staphylococcal penicillins, the aminopenicillins. The aminopenicillins can be used with beta-lactamase inhibitors. The extra extended spectrum penicillins and the extended spectrum penicillins can also be used with beta-lactamase inhibitors. So these are the various parenteral agents which come under these broad categories of penicillins. So what is the mechanism of action? So in a nutshell, it is basically the penicillin group of antibiotics, like any other beta-lactams. They inhibit the bacterial growth by inhibition interfering with the transpeptidation reaction of the bacterial cell wall synthesis. So what is the transpeptidation reaction? So in a bacterial cell wall, which is a complex structure, which is a polymer of polysaccharides and peptides. This is known as peptidoglycan, that is peptides along with polysaccharides, that is peptidoglycan. So the polysaccharide has got alternating amino sugars in it because it is a saccharide. It has got sugars, and this amongst the sugars, a 5 amino acid peptide is linked to the into one of the sugars, that is N-acetylmuramic acid. And this particular 5 amino peptide terminates in D-alanine, D-alanine. Okay, so this is what is the basic structure of a peptidoglycan cell wall of a bacterial cell wall consisting of peptidoglycan. So what happens is when beta-lactam antibiotics, which are naturally structural analogs of this D-alanyl D-alanine substrate. That is, these are the analogs. They covalently bind with the active site of the penicillin binding protein. So when they act with this, they actively bind to the active site of penicillin binding proteins. It inhibits the transpeptidation reaction and halts the peptidoglycan synthesis, and thus the cell dies. So if you see here, this is better represented in this figure. So if you see, this is a normal cell wall, bacterial cell wall peptidoglycan synthesis transpeptidation reaction. So if you see here, these are two peptides here, and this is a transpeptidation reaction which is happening. So this is the transpeptidase enzyme, which acts and produces transpeptidation reaction over here. This is the enzyme, and this enzyme acts here and produces a transpeptidation. So what happens is beta-lactams, when they come into the picture, they bind to the transpeptidase. So if you see here, this transpeptidase has bound with beta-lactam here, and they bind it at the beta-lactam, that is the penicillin binding protein site. Okay, so this is the site here on this red dot here. This is the site. So the transpeptidase binds with the beta-lactam ring at the penicillin binding protein site, and thus there is an inhibition of the transpeptidation reaction between these two molecules, which was supposed to happen in this manner. So there is an inhibition of the transpeptidation reaction, and thus the peptidoglycan synthesis cannot happen anymore. So this is how a beta-lactams antibiotics, they basically work and kill the microbes, the bacterial cell wall. So what is the antimicrobial activity of the various penicillins? If you see natural penicillins, they are usually, if you see the gram-positive, they have to be used with caution. Gram-negative is completely out of the picture. You cannot give it there. Anaerobes, again, with some amount of caution, and atypicals, you can't give it there. So basically, the spectrum is extremely poor for natural insulins. So what about anti-staphylococcal penicillins? Amongst the penicillins, second group is the anti-staphylococcal penicillins. If you see here, everything is a stop except for some amount of caution and some coverage of the gram-positive bacteria. So this also is extremely very small in its spectrum. And what about the third group? That is the aminopenicillins. If you see here, or in aminopenicillins, atypical species are a complete stop, whereas the gram-positive, negative, and anaerobes are to be used with a certain amount of caution with aminopenicillins. And these are the various spectrum that the aminopenicillins cover in terms of bacterial killing. And what about the aminopenicillins if used with beta-lactamase inhibitor combinations? So if you see here, gram-positives, they are decently good. Anaerobes, it is decently good. Gram-negative still remains in caution, and atypicals are a complete stop again. So if you see in comparison to only aminopenicillins, if you use a beta-lactamase inhibitor, you get a little more better activity with gram-positives and anaerobes in case of aminopenicillins. So what about extended spectrum penicillins? A little bit focus on it. Reveals that it consists of piperacillin and picaracillin. And what they have more beneficial in terms of the other penicillins is they have greater penetration into the gram-negative bacilli. These are the most important pathogens in today's day and age. And that is why these extended spectrum penicillins have greater penetration and greater activity against this gram-negative bacilli. They do have some amount of gram-positive activity as well, like the natural penicillins of that is the first group, but like the natural penicillins, they are also susceptible to the beta-lactamases of the staphylococci. So they are not very good in terms of their gram-positive coverage, but gram-negative coverage, they are definitely better than the previous groups of penicillins. So if you see, these groups are the ones that is gram positive, you can decently good. Gram negative is decently good. Anaerobes as well, there is certain amount of coverage of Clostridia and Bacteroides. But remember, the Clostridia is except the Clostridium difficile. It doesn't cover the Clostridium difficile, and atypical is you can't use it for atypical organisms. So what about the pharmacokinetics of the penicillin group of beta-lactams? They are rapidly excreted by the kidney. The ampicillin is the one which has biliary excretion. Oxacillin, dicloxacillin, and cloxacillin have both kidney and hepatic excretion. So they do not require any dose adjustment in renal failure. So this is one of the good things about using these three groups of antibiotics. So normal half-life is around 30 minutes. And remember, the half-life of ampicillin and extended spectrum penicillins like piperacillin is slightly higher. Piperacillin and ticagrelor is slightly higher at 1 hour. So remember, what the pharmacokinetics of beta-lactams is extremely important. This will be asked to you in your exams time and again. So you have to remember that beta-lactam antibiotics are time dependent, and the time above MIC is the one that is associated with the clinical efficacy of the antibiotic. So the amount of time that the antibiotic concentration remains above MIC. So they have seen studies that bacterial killing occurs when the time above MIC is 50% of or more of the dosing interval. So suppose the dosing interval is tedious and you have 8 hours of dosing interval, at least 4 hours of time above MIC should be maintained. And in case of penicillin, it is around 50%, that is around 4 hours. In case of cephalosporins, it is 60 to 70%. And in case of carbapenems, it is around 40% of the time which has to be above the MIC. So if you see in critically ill patients, if you can increase the time above MIC, it has led to better outcomes in case of beta-lactam antibiotics. And remember, maximum killing effects and suppressed bacterial resistance occur when the antibiotic concentrations remain 4 to 5 times above the MIC. So if you are achieving antibiotic concentrations, if it is decently higher than the MIC, there is a good amount of bacterial killing as well. But remember, the beta-lactams are basically all time-dependent antibiotics. They are not concentration-dependent antibiotics. So RRT efficiently eliminates most beta-lactams. So you will have to give a post-RRT dosing of beta-lactam antibiotics. So recent meta-analysis has shown that continuous infusions of beta-lactams have produced a certain better clinical cure and mortality in severely septic patients without RRT. So this is one of the things you have to remember, that continuous versus bolus infusion, which is the one which is better. So as of now, certain amount of mortality benefit in certain subgroups of patients, like severely septic without RRT, but rest of the patients there have not been any mortality benefit. So what about resistance? This is an important thing in beta-lactams. If you see, there are four primary mechanisms which are responsible for resistance. The first is a modification of the penicillin binding protein. So the second is a deficiency or loss of the outer membrane protein. The third is a active efflux system. And the fourth is a beta-lactamase production. I mentioned it in the previous slides that beta-lactamase is one of the mechanisms, but there are the other three mechanisms. The first is modification of the PPB, the deficiency. Second is the deficiency or loss of the outer membrane protein or OMP. The third is the active efflux system, and the fourth is the beta-lactamase production. So what are the adverse effects? Adverse effects are mostly in terms of hypersensitivity. So the antigenic determinants in penicillins are basically the penicilloic acid and products of alkaline hydrolysis, which then bind to the host protein. And this is how the allergenicity comes for the penicillins. If you see, less than 1% of patients who previously received penicillin will have an allergic reaction when given penicillin. So it's a very less number of patients, but definitely you will have to do a penicillin skin testing before using it on any patient. And you have to evaluate for a type 1 and hypersensitivity reaction when you do the skin testing. If skin testing is negative, you can proceed to give the particular penicillin. So anaphylactic reactions have also occurred in penicillin usage, and you have to be very careful. There can be several severe anaphylactic reactions as well, and you can have hemolytic anemia and hematological disturbances as well with penicillin usage. And most patients who are allergic to penicillin have to be treated with alternative drugs. And patients once allergic to penicillin should be considered as being cross-allergenic to other beta-lactam antibiotics as well. So that you have to be very careful when you're giving cephalosporins, when you're giving your carbapenems or monobactams. So you have to be extremely careful. So to summarize, if you see, the anti-staphylococcal penicillins are inactive completely against the gram-negatives. The natural penicillins have activity against the Neisseria meningitis and some strains of H. influenzae, but very few other gram-negative bacteria. The spectrum of aminopenicillins is slightly more, to include some enteric gram-negative rods such as E. coli and Shigella, but they do not produce the beta-lactamases. This is important. If beta-lactamases come in, the aminopenicillins are of no use. The extended spectrum penicillins are even more active against the gram-negative rods. And most importantly, the extended spectrum penicillins like piperacillin are active against Pseudomonas aeruginosa. And if you do add a beta-lactamase inhibitor to an extended spectrum insulin, there is a slight more increase in the amount of gram-negative bacilli that is included in the spectrum. So what about cephalosporins? Cephalosporins are similar to penicillins, but they are more stable to many of the beta-lactamases, and therefore they have a slightly more higher spectrum of activity. So we have to remember few generalizations about the spectrum of activity, that in the first, with the exception of the new fifth generation agents, each successive generation of agents has broader activity against gram-negative bacteria. So as you move from your first generation to fourth generation, that is increasing gram-negative activity. And you have to remember that with some exceptions, cephalosporins have very poor anaerobic activity. And third, the activities of these agents against gram-positive bacteria is variable, with the fifth generation agent, that is ceftaroline, having the highest activity against these bacteria. Although the fifth generation ceftaroline is not being used so much in India, you have to remember there is an agent in fifth generation called as ceftaroline. So these are the various agents, that is the cephalosporins, first, second, third, fourth, and fifth generation. And this is the antimicrobial spectra of the first generation. If you see here, there is some gram-positive activity, but not much of other activity. As you move towards the second generation, you have some gram-negative and anaerobic activity as well, but no atypical coverage. And as you move uh, towards the fourth generation of cephalosporins, you have more of gram-positive coverage, and gram-negative coverage is decently good, and anaerobes and atypicals are not covered. So if you see third generation cephalosporins, I missed out, but definitely they have more amount of gram-negative coverage. So what are the adverse effects? Like the penicillins, the cephalosporins uh, can have hypersensitivity reactions if they have got a history of penicillin allergy. So you have to be careful and do a skin testing. So to summarize, cephalosporins are varied in their spectrum, but the following generalizations are there. That is, the first generation agents have good gram positive coverage. Second generation agents have modest gram positive coverage, gram negative coverage, and in some cases, some amount of anaerobic coverage. Third generation agents have very strong activity against gram negative bacteria. Fourth generation agents have enhanced activity against more amounts of gram negative bacteria. And as I said, fifth generation agents have good activity against gram positive bacteria as well. So coming to the carbapenems, they are the most broadly active antibiotics used today, and they are the last line of agents against the resistance that is coming in our ICUs. There are four members to this class: imipenem, meropenem, doripenem, and ertapenem. And if you see, the structure of the carbapenems is related to the penicillins and cephalosporins in terms of having a beta-lactam ring. If you see here, this is the beta-lactam ring, and the variability in the structure of the carbapenems is with respect to this. These are the blue shaded areas. And if you see, there are three properties which are different in the carbapenems, which lead to an incredibly broad amount of spectra in these carbapenems. So coming to the first antibiotic, that is imipenem. Structurally, it lacks an R1 side chain. This is not very important, but what is important is you have to remember that it is very rapidly destroyed in the kidney by an enzyme called dihydropeptidase 1. So as a result, it is administered with silestin, which is an inhibitor of this enzyme dihydropeptidase 1, and thus it increases the half-life and decreases the nephrotoxicity of imipenem. This is one of the questions that examiners keep asking, that how does silestin help with with the use of imipenem. It increases the half-life and decreases the nephrotoxicity of imipenem. So what about meropenem? So meropenem also is a broad spectrum carbapenem, and it is more active against gram-negative rods, including Pseudomonas as well. And it is slightly lesser active than gram against gram-positive cocci, including Staph aureus. So the standard dosing is usually 1 gram IV every 8 hourly. And if you see, the recommended dose is for skin and soft tissue infections, skin and skin structural infections is 500 mg TDS. But for every other indication, it is 1 gram TDS, intra-abdominal infections, nosocomial pneumonia, all of this. But remember, IDSA actually gives recommendations of using meropenem in 2 gram IV TDS doses. So it should be administered as an intravenous infusion. And remember, nowadays there has been evidence of meropenem usage in continuous infusion. So it has to be given over an infusion of 3 hours. You can ignore this as 15 to 30 minutes. You have to give it over 3 hours. So renal dose adjustments. If you see adults, according to the creatinine clearance, you can do the renal dose adjustment. It will be written on the package insert of the meropenem as well. So, what is the evidence for continuous versus intermittent infusions of antibiotics for the treatment of severe infections with the use of meropenem? So, if you see recently, there has been a lot of evidence and a lot of literature on whether to use continuous or intermittent infusions. So, intermittent infusions also mean that the patient will get at least 3 hour infusions, and continuous means that it should be continued over 8 hours, the whole infusion. So there will be a continuous infusion in a TDS dose running 24/7 on that patient. Intermittent infusions mean that in an 8 hour dosing, you have to give the infusion over 3 hours. So this is what is the current evidence regarding the use of continuous versus intermittent infusions, that there has not been any particular benefit of either of the two methods. So as of now, we will continue our practice of giving intermittent infusions over 3 hours. So the rationale for prolonged infusions are that to increase the amount of time that you keep the MIC, keep your concentrations of the drug above the MIC. And what about the synergy of using carbapenems with polymyxins? There has been multiple systematic reviews and meta-analysis of checking for synergy of polymyxins and carbapenems. So colistin alone versus colistin plus penopenem for the treatment of severe infections. So definitely at this point of time, even though there is no mortality benefit in terms of morbidity and the reduction of the emergence of multi-drug resistance bacteria and further resistance, use of combination therapy is recommended. So patients allergic to penicillins may also be allergic to carbapenems, and the same set of hypersensitivity reactions might happen with carbapenems. So what about resistance? It's an important question that we will get in your theory exams about the two globally accepted beta-lactamase resistance classifications. One is called as the Ambler classification, that is the Ambler class A to D, and the second is the modified Bush-Jacobi-Medeiros classification based on functionality, where it is group 1 to 3. So for all practical purposes, the Ambler classification is the one which is used very frequently. So class A, D, and C function by serine ester hydrolysis, whereas the class B, which is also known as the metallo-beta-lactamase, has got a zinc ion and which participates in catalysis. So this is slightly different than the class A, C, and D. In the classification same used by the Bush-Jacobi classification, there are 3 groups. That is group 1 cephalosporinases, group 2 serine beta-lactamases, and group 3 metallo-beta-lactamases, which are again each divided into several subgroups. So if you see the Ambler classification, this is the class A, B, C, and D. If you see class A, these are the ESBLs. The frequent resistance mechanisms here are the TEM, SHV, and the CTXM. And carbapenemases in this include the KPC. What about B? B is got metallo-beta-lactamases, which includes WIM, IMP, and the dreaded NDM. What about class C? C has got the AMC chromosomal beta-lactamases. And what about class D? Class D includes the oxacillinases and the ESBLs and the carbapenemases. And the genes for this include the OXA23 and OXA48. OXA48 is one of the most common mechanisms in class D. So now that we finished the beta-lactam antibiotics, we proceed a little bit into one of the newer antibiotics, that is ceftazidime avibactam. So if you see, it is a parenteral anti-pseudomonal cephalosporin, that is ceftazidime avibactam. And how this avibactam, this ceftazidime avibactam is extremely important is avibactam inhibits the ESBLs, AMC beta-lactamases, and class A carbophenamases. So if you see, the avibactam has activity against class A, C, and D beta-lactamases. And if you add astronam to the ceftazidime avibactam, that is the avibactam part of it, if you add astronam, it will cover for the group B or the metallobeta-lactamases as well. So that's the rationale behind using ceftazidime avibactam and astronam. So what is the mechanism of action? I did tell you that the avibactam has activity against all the classes except class B, that is the NDM, IMP, and WIMP. So if you see, the avibactam has got activity, yes, against class A, C, and D, but not against class B. So what about the PKPD? You have to give ceftazidime avibactam 2 gram with avibactam 500 mg every 8th hourly. This has to be infused over 2 hours. Okay, so this is extremely important. This is again a beta-lactam antibiotic which has to be infused over infused as an intermittent infusion over 2 hours. This is the creatinine clearance in the dosing. If you see, this is a time-dependent antibiotic and no hepatic dose adjustment is necessary. So spectrum of activity, I have already discussed. Pseudomonas, enteric gram-negative rods, and a certain amount of streptococci, but it does poor activity against most anaerobes, MRSA, MSSA, all of this. And for that matter, Acinetobacter and Stenotrophomonas as well. Acinetobacter is notorious for possessing the group B metallobeta-lactamases, and that's why ceftazidime avibactam doesn't have good activity against Acinetobacter. So what about uses? It has been FDA approved for complicated UTI, complicated intra-abdominal infections, and HAP and VAP. And there are definitely hypersensitivity reactions. Since it is a beta-lactam antibiotic, it can cause Clostridium difficile associated diarrhea for with prolonged usage. And probenecid decreases the elimination of avibactam, and it can increase the amount of avibactam in your body and produce nephrotoxicity. And this is some amount of evidence, the reprise trial as well as the reprove trial, which have shown that ceftazidime avibactam has been very helpful in the treatment of multi-drug resistance pathogens. And their comparisons with meropenem have been that it is non-inferior to meropenem with nosocomial pneumonia, okay, and even other intra-abdominal infections. So this is the recent evidence that the reprove and the reprise trial speak about the ceftazidime and avibactam. So this is just a summary of the various mechanisms of action of various antimicrobials. So the polymyxins are here, the beta-lactams, the quinolones, tigecyclines, the aminoglycosides. So this is basically a gram-negative bacterial cell, which consists of a outer cell wall here, and this is an outer membrane. This is the periplasmic space, the cytoplasmic membrane, and the cytoplasm over here. So these are the various mechanisms of the various antibiotics by which they act. So coming to the antifungals, if you see, the antifungals are basically classified into either polyenes, echinocandins. They're either antimetabolites like flucytosine, or they can be azoles. And amongst the azoles, the most common is the fluconazole and the voriconazole. So this is the various mechanisms by which the antifungal agents act. Azoles act in prevention of conversion of the lanosterol to the ergosterol. The amphotericin B creates pores in the bacterial cell membrane, and the echinocandins inhibit the synthesis of beta-glucan synthase inhibit the beta-glucan synthase enzyme and inhibit the formation of the bacterial cell, of the fungal cell wall. So these are the various mechanisms by which the antifungal agents act. The flucytosine acts on the DNA level of the fungus. So if you see, this is the fungus cell membrane and cell wall here, which I have shown. And this is the ergosterol synthesis pathway over here. So the first and foremost is the amphotericin B. It is a broad spectrum antibiotic, and it has got very poor CSF concentrations of 2 to 3% of the blood concentration. And it has got very high concentration in the intra-abdominal organs of liver and spleen and bone marrow as well. So why is it an important agent? Because it has got activity against both Candida as well as Aspergillus. So the mechanism of action I mentioned you in the previous slide, that it causes micropores in the fungal cell membrane, and thus the ions, amino acids, and water soluble substances move out and increases the permeability, and thus it destroys the fungus. So antifungal spectrum is basically, it has a lot of activity against Candida and Aspergillus. Even Cryptococcus, the drug of choice, has been amphotericin, and even Histoplasma amphotericin has been used. So the pharmacokinetics, it is not absorbed orally. It has to be administered as IV, and it is given as a suspension as with either deoxycholate. And it has a very high amount of tissue binding, which is there. And it is metabolized 60% in the liver and an elimination half-life around 15 days. So what about the administration and dosage? It can be administered orally for intestinal moliniasis or for vaginitis or otomycosis. But usually in critically ill patients, you will give it IV, and conventional amphotericin B is given a dose of 3 to 5 mg per kg. So what about lipid formulations? That is liposomal amphotericin B. It has got, these are the newer lipid formulations which are available. It is much more expensive. And the good thing is it has got reduced toxicity, and also it enhances the efficacy. So liposomal amphotericin B has much higher efficacy than the conventional amphotericin B, and the dosing is around 3 to 5 mg per kg. And another formulation called as the amphotericin B colloidal dispersion has also been produced, but it is not superior to the other variants of the liposomal amphotericin B. So what the uses of amphotericin B? As I said, it can be used for life-threatening mycotic infections, which includes both Candida as well as Aspergillus, and along with it, Histoplasma and Cryptococcus as well. So what are the side effects? This is one of the favorite questions for all examiners. There can be a lot of infusion-related side effects like fever, convulsions, nausea and vomiting, and there can also be cumulative toxicity in terms of nephrotoxicity, potassium and magnesium wasting, and anemia. So to reduce the infusion-related reactions, it is always recommended to give a pre-treatment with antipyretics, antihistamines, and antiemetics. So what are the key points of amphotericin? It is not absorbed enterally. It can be given for intestinal candidiasis. This is the reason why it has to be given in intestinal. It is not absorbed enterally, so it acts inside the lumen of the gut. So drug concentrations achieved in the skin is extremely low, so it is ineffective against the superficial skin infections. And penetration in the brain and CSF is extremely poor, but when used with 5-flucytosine, it is extremely effective in fungal meningitis. So coming to the echinocandins, caspofungin, mycofungin, and anidulafungin. So this is the newest class of antifungals, and it is active against Candida and Aspergillus, but not against Cryptococcus neoformans or against mucormycosis. So it is predominantly a Candida treatment. It is for use for Candida treatment and as a second agent for Aspergillus treatment. So basically, I showed you in the initial slide, the mechanism of action is basically inhibition of the synthesis of the beta D of the beta glucan in the fungal cell wall, and this leads to the cell death of the fungus. So caspofungin is the prototype member of the echinocandins, and it is mainly active against Candida and to certain against Aspergillus. There has been increasing amounts of resistance seen through azoles nowadays. And in recent data, there has also been resistance to echinocandins as well, which is being seen because of the development of the multi-drug resistant fungus which are coming through. So what about the pharmacokinetics? It is not absorbed orally, so it has to be given IV. It is distributed to the tissue but does not enter the CSF. So remember, the CSF penetration is extremely poor. So fungal meningitis is not something where caspofungin has to be used. And it has extensive metabolites which are excreted in the urine. And definitely it is again also not very helpful for your UTIs. So caspofungin is used for deep and invasive candidiasis and candidemia of the blood. And it is also a salvage therapy in case of invasive aspergillosis, which are not responsive. So because of the good tolerability, it is increasingly being used in immunocompromised and neutropenic patients. And it is given as a 70 mg loading dose, infused IV over 1 hour, followed by 50 mg IV daily dosing. So what about micafungin and anidulafungin? Micafungin is given as a 100 mg IV dose for candidemia. And similarly, anidulafungin is given as a 200 mg IV loading dose, followed by a 100 mg IV OD dose. So adverse effects of echinocandins are extremely less. It is well tolerated. It can produce, caspofungin can produce a certain amount of elevation of the liver enzymes. Anidulafungin is much better than caspofungin in terms of that there is less hepatotoxicity with anidulafungin. So what about fluorocytosine? It is a pyridimidine antimetabolite and it has got a good amount of CSF concentration. It is approximately 75 of the serum, 75% of the serum concentration, and thus it can be used in fungal meningitis. So flucytosine is initially converted to 5-deoxyfluorodeoxyuridine monophosphate and 5 and fluorouridine triphosphate, and this inhibits the DNA and RNA synthesis respectively of the fungus. And clinical use is definitely confined only as a combination therapy with amphotericin B. I did mention under amphotericin B, when amphotericin B is used with flucytosine, 5-flucytosine, it has got improved outcomes with cryptococcal meningitis. And itraconazole, it can be combined flucytosine with itraconazole for chromoblastomycosis as well. So what are the adverse effects? The most common adverse effect is the bone marrow toxicity, which causes anemia, leukopenia, and thrombocytopenia. And there are GI disturbances as well with 5-fluorocytosine. So you have to remember what are the key points. So this is a narrow spectrum fungistatic agent and not fungicidal. CSF penetration is the most important thing for this, and it is extremely good, and hence it is combined with amphotericin B in fungal meningitis. So what about the azoles? So azoles, as I previously classified as well, the most important azoles are the triazoles, which are the fluconazole and voriconazole. So the mechanism of action of the azoles, I did tell you that it inhibits the conversion of lanosterol to ergosterol and reduction in the amount of ergosterol synthesis. So if you see, this is the place where the azoles act. There is inhibition of the lanosterol to the ergosterol conversion of the bacterial cell membrane. And what are the clinical uses? It has got varied uses. It has got activity against Candida, Cryptococcus, Blastomyces, Histoplasma, Coccidioides, and the dermatophytes. But remember, in ICU practice, Candida, Cryptococcus, Blastomyces, and Histoplasma are the ones that you will encounter very regularly. And amongst them as well, you will have most commonly the Candida species that you will encounter where azoles will be used. But the incidence of azole resistance has increased dramatically. And in India, as per the latest data, there is almost a 40% of the Candida species are resistant to the azoles. And it is relatively non-toxic, and there can be some hepatotoxicity with elevation of the liver enzymes. So it has got a broad antifungal spectrum. And as I said, the mechanism of action I mentioned in the previous couple of slides. The usual dose is around 200 mg OD or BD for fluconazole. And fluconazole, if you see, it is a broad spectrum drug. It can be used in various conditions and systemic infections. It can be used. If you see fluconazole dosing, that as per the package insert, there are various dosages of fluconazole for various different fungal infections. So you have to see which fungal infection you are treating and then dose your fluconazole accordingly. If you see voriconazole, you have to remember that the drug of choice for the treatment of aspergillosis is voriconazole. And you have to remember that this is for all invasive aspergillosis as well. It is the treatment of choice. And it is definitely superior to amphotericin B.
Sorry, Shiva.
So what is the dose of fluoroconazole? It is around 6 mg per kg, 2 doses, 12 hours apart, followed by 4 mg per kg, 2 doses. And if you use orally, which is usually not what we use in ICU patients, this is only when you can de-escalate the IV dose to the oral dose when your patient is going from the ICU to the wards. This is around 200 mg per oral BD. So what about posaconazole? This is a newer triazole. It has the broadest spectrum amongst the azole families. And this is the only azole, if you see, which has got activity against mucormycosis. And this was one of the agents which has been recommended during the COVID pandemic in case of when there were increased incidence of mucormycosis. Dosages around 100 to 400 mg per oral, Q12H to Q24H for oropharyngeal candidiasis. But for mucormycosis, you have to give a very good high dose, that is 400 mg per oral BD. Thank you for your patient listening. This is just a brief overview of all the antibacterials and the antifungals. Thanks a lot.
Thank you, Rohit sir. Now we will move to the next session. The next session will be a class on fast hug, sedation, analgesia, and also delirium. This topic will be taken by Dr. Abhilash Dash, Associate Professor, Department of Critical Care Medicine. I would like to invite Dr. Abhilash sir to please carry on with the session.
Am I audible?
Yes, sir.
Okay. Good afternoon, everyone. My topic is fast habits, sedation, analgesia, delirium. Very common topic, but very useful. And usually we tend to neglect this thing. So I'll start with fast habits. So give your patient a fast hug at least once a day. It was said by Vincent in 2005. So fast hug was started in 2005. Then he updated this to fast hugs bid in 2009. So what is fast hugs? So the mnemonic is A for feeding or fluids, A for analgesia, S for sedation, T for thromboprophylaxis, H for head and elevation, U for ulcer prophylaxis, glycemic control, spontaneous breathing trials, bowel care, indwelling catheter removal, drug de-escalation. So why we should use this? Followed for a care of critically ill patients. As a checklist is a simple strategy which is used for identifying and checking the significant aspects of general care in ICU. So for proper general care, this is very important. It is a systematic approach to patient care, which is usually repeated throughout work shifts. In every shift, you have to check the faster with this mnemonic. Prevent errors of omission in the basis of domain of ICU management. Okay. So it improves the quality of patient care. It increases the safety and efficacy of patient care. It encourages teamwork. So starting with feeding or fluids, whatever. Why feeding? Because malnutrition can lead to impaired immune function, which can lead to increased susceptibility to infection, poor wound healing, bacterial overgrowth, chances of decubitus ulcers, prolonged ICU and hospital stay. So we should immediately focus on feeding once the patient gets admitted to ICU. Okay. It may be enteral feeding, it may be parenteral feeding, but enteral feeding is encouraged within 24 hours of any illness. Then analgesia and sedation. This administration optimizes the patient comfort and minimizes the acute stress responses like hypermetabolism, increased oxygen consumption, and critically ill patients, they can feel pain from the acute illness. Any devices that are used in patients like endotracheal tubes, all the invasive lines, or any procedures like suctioning, dressing changes. So analgesia is very important. So sedation in critically ill patients is principally used to control the agitation, to enable the effective care, to facilitate ventilation and minimize the asynchrony between patient and ventilator, to prevent accidental extubation or accidental removal of the vascular catheters, and control intracranial pressures and reduce the metabolic rates, which will lead to decreased oxygen consumption. Then coming to thromboprophylaxis. In all ICU patients, there is a high chance of venous thromboembolism and also pulmonary embolism. To prevent this in patient with prolonged ICU stay with intubated state or immobility state, we need to do thromboprophylaxis. What are the drugs we can use? We can use heparin or low molecular heparin or dalteparin or whatever. These drugs can be used according to the patient's renal status and weight. These are pharmacological thromboprophylaxis. Mechanical devices also can be used, and elastic compression stockings can be used in thromboprophylaxis. Then head-up positioning, bedhead elevation to prevent aspiration and VAP. Elevating the head of bed to 30 to 45-degree angle will reduce the occurrence of reflux, GI reflux, and it will prevent chances of aspiration during enteral feeds. And nosocomial pneumonia or VAP can be prevented. Then coming to ulcer prophylaxis. To prevent the gastrointestinal bleeding and to prevent the stress ulcers in ICU. It is very important, but most of the patients, what we use are mechanical ventilator patient more than 48 hours, or patient having prior ulcers, known gastric or duodenal ulcer patients, and patient having coagulopathy like platelet less than 50,000, INR more than 1.5, or APTT more than 30. Then traumatic brain injury patients and spinal cord injury patient or burn patient where curling ulcers are very common, we should use. And some in other patient like septic patient also, sometimes we use. Then a very important step is glycemic control. So the glycemic control is very necessary in critically ill patient to decrease the complications like wound healing, infection, and polyneuropathy. And we have to prevent glycemia and hyperglycemia both. Hypoglycemia is very dangerous in patients, and hyperglycemia is also dangerous. So our target should be around 140 to 180 milligram per deciliter in medical ICU patients. Then coming to the bowel care. So constipation, diarrhea both should be prevented in ICU. Diarrhea can lead to electrolyte imbalance, dehydration, hemorrhoids like this, and delirium. And even constipation can lead to patient discomfort, intolerance to feeds, and delirium. So evaluation and maintenance of the proper bowel function is necessary to prevent the complications. Then indwelling catheters. Lot of catheters are being put in patient like Ral's tube, Foley's, and central venous catheter, arterial lines or peripheral lines, whatever. We have to mention the date, how many days this catheter is inside the patient, and what is the need, whether this can be removed. Every day there should be an assessment. In fact, in each shift there should be an assessment whether to continue with that catheter or remove, so that we can prevent COTI or CLAPSI or any other catheter-related complications. And finally, coming to drug de-escalation. So de-escalation therapy, it is defined as a changing from a broad spectrum to narrow spectrum antibiotic based on the culture data. Then changing the focus from multiple antibiotic to a single drug when suspected organism detected by a culture to reduce the antibiotic overuse and also prevent resistance. And then spontaneous breathing trial or supplemental oxygen, whatever. Mainly spontaneous breathing trial. In any patient on ventilator, every day we have to assess whether the patient can be extubated. So before extubation, you have to give a breathing trial for these patients. So faster beats is completed. Now I will start with analgesia. So hypernociception. Critically ill patients experience more pain than others because of prolonged immobility and systemic inflammatory responses. There are few psychological factors also leading to hypernociception, like anxiety, depression. In patient of young age, one or more comorbidities and any history of surgery, these patients will also are more likely to feel more pain. So what are all the painful stimulations in ICU? Mainly endotracheal suctioning, turning in the bed, and all the invasive procedures. They may cause severe pain. So how to monitor pain? Actually, pain is an unpleasant sensory or emotional experience. It is very subjective in nature, can be described in terms of intensity, duration, location, and quality. Most often, monitor parameter is the intensity. So there are few scales where we can assess the pain and score it. Maybe self-reported scales or maybe observational, like numerical rating scale, facial pain scoring. These are self-reported scales. And behavioral assessment tools are those where the patient is on ventilator, like behavioral pain score and critical care pain observation tool, CPOT. So this is a numerical rating scale. Score is from 0 to 10. No pain is 0. Worst possible pain is 10. In numerical rating scale, score of less than 3 or less is adequate. And in behavioral pain score, there are few components like facial expression, upper limbs, compliance with the ventilator. Total score is 12, and if the score is less than 3, then patient is not having any pain. 3 to 7, mild pain. More than 7, moderate to severe pain. And another, as I told, is critical care of pain observation tool. There, along with these three components, there is a component of muscle tone. There also the score is from 0 to 8. Less than 2 score is less pain, no pain. 2 to 5 is moderate pain, and more than 5 is severe pain. So, so how to prevent pain or minimize the pain? We have to use analgesia. Most commonly, we use opioid analgesics, the natural derivative of opium. These products affect by acting on the opioid receptors like mu, kappa, and delta receptors. These are most frequently used. They produce analgesia, mild sedation, but no amnesia. So most commonly used are morphine, fentanyl. Coming to morphine mechanism of action, pharmacokinetics and pharmacodynamics. The onset is 5 to 10 minutes. Duration is 6 hours. It is not lipid soluble. It has active metabolites like morphine 3 and morphine 6 glucuronide. It has histamine release action. And in renal failure, we have to adjust the dose. The bolus dose is 2 to 5 milligram, followed by infusion of 2 to 4 milligram per hour can be used. Then fentanyl, the onset is 2 to 5 minutes. Duration is 1 to 2 hours. It is highly lipid soluble. It has no active metabolites. It has no histamine release property. Dose as adjustment is not required in renal or liver failure. Bolus dose is 50 to 100 mics per hour, and infusion, 50 to 100 mics, and infusion is 1 to 5 mics per kg per hour. So what are all the advantages of fentanyl over morphine? It has rapid onset of action. It has strong analgesia, low risk of hypotension than morphine. It has absence of active metabolites, useful in the renal impairment also. Remifentanil is a relatively newer opioid. It is ultra short acting. It should be given by continuous infusion. The dose is 1.5 mics per kg loading, followed by 5 to 10 mics per kg per hour. It has analgesic effects, which is lost within 10 minutes. Metabolism is by plasma hysteresis. So can be used in renal and hepatic failure. The context sensitivity half time is very low in remifentanil. Other drugs are also being used like pentazocine, buprenorphine, butorphanol, pethidine. What are all the adverse effects of opioids? The most important is the respiratory depression, the centrally mediated and dose-dependent action. There is a decrease in the respiratory rate, but the tidal volume remains same. Most commonly, COPD and OSA patients are very prone to this adverse effect. In usual doses, respiratory depression is less common. Nausea, vomiting also can occur due to stimulation of the chemoreceptor trigger zone. In CVS, blood pressure and heart rate both can be decreased due to decreased sympathetic activity, increased parasympathetic activity, and this is seen more in volume depleted patients and heart failure patients. And when opioids are used combined with benzodiazepines, there is a more chance of hypotension or bradycardia. And in GI system, there is a depression of GI motility leading to constipation, reflux, and chance of aspiration. So if there is a overdose of opioids, we can use a drug called naloxone. It can reverse the respiratory depression and even the depression of the sensorium. In respiratory depression, the dose is IV naloxone, first 2 milligram, then 4 milligram, then 10 milligram, then 15 milligram of incremental dose every 3 minutes till reversal of the respiratory depression. And for depressed sensorium, 0.4 milligram, followed by 0.4 milligram, followed by 2 milligram every 3 minutes. Can be given in multiple routes like IV, IM, intratracheal, and even intraosseous. Bolus dose should be followed by infusion to maintain the drug effect. Then acetaminophen, IV paracetamol used for pain and fever control was approved actually in 2010. You know the maximum dose, it is around 4 gram per day. Then it has opioid sparing effect. It has no anti-inflammatory activity. It is high risk of hepatotoxicity. What is the recommendation of PADIs? Used as an adjunct to opioid to decrease pain intensity and opioid consumption for pain management in critically ill patients. Coming to ketamine, it is a phencyclidine derivative. It produces hypnosis and it has profound analgesic effect. It is an NMDA receptor antagonist. It acts at the reticular activating system and also at the spinal levels. The onset of action is very quick at 30 seconds. Duration is around 10 minutes. And the dose is 1 to 2 milligram per kg bolus IV. It can be used as an induction agent in hypotensive patients. It is very useful in bedside painful procedures like burn dressings and any other painful procedures. So what is the recommendation of use? You can use it as a low dose at 0.5 milligram per kg IV bolus followed by 1 to 2 mics per kg per minute infusion as an adjunct to opioid therapy when seeking to reduce the opioid consumption in post-surgical patients mainly. Not in medical patients, mostly in post-surgical patient, you can use ketamine to spare opioids. So what is the recommendation of the procedural pain? So you can use opioid at the lowest effective dose for procedural pain management in critically ill patients. Even we can use NSAID, either IV or orally or rectally, as an alternative to opioid for pain management in critically ill patients. Even cold therapy can be used in some specific procedures like intercostal drain placement. For neuropathic pain, the recommendation is to use a neuropathic pain medication like gabapentin, carbamazepine, pregabalin with opioids for neuropathic management in critically ill patients, like in GBS patients, post-cardiac surgery patients, where there is more chances of neuropathic pain. We can use carbamazepine 100 milligram 4 times per day or gabapentin 600 milligram thrice a day. These drugs are given enterally, most commonly. Coming to the sedation part, process of relieving anxiety and establishing a state of calmness is called sedation. Definitive treatment is the drug therapy. So supportive measures like communication with patient, allowing family members, promoting sleep also help in calming the patient. Monitoring of the sedation is done by various scales like Richmond Agitation Sedation Score, Ramsey Sedation Score, Rickers Sedation Scale. So this is the Richmond Agitation Sedation Scale. It is, the score is from -5 to +4. How to assess? First, you have to observe whether the patient is alert or not. If the patient is awake or alert, then score of 0 to +4 can happen. If the patient is not alert, then you have to stimulate the patient verbally by addressing his name loudly and ask to look at you. And accordingly, you give a number of -1 to -3. If there is no response, then you have to stimulate with the patient physically, shake the patient's shoulders, then rub the sternum and give a painful stimulus. If still not arousable, then score may be from -4 to -5. Our target score level should be -1 to -2. So that patient is light sedated, briefly awakens to voice within 10 seconds. This is Ramsey sedation score, mostly same. The level we want to achieve is level 2 or level 3, where the patient is awake, tranquil, cooperative, and responds to commands. And Rickers scale is also can be used. So what are the drugs used to sedate the patient? Previously, most commonly used drug group was benzodiazepines. It has dose-dependent amnestic effect along with the sedative effects. It also has anticonvulsant and muscle relaxant properties. Sedatives of choice in the drug withdrawal syndromes like alcohol withdrawals, opioid withdrawals, and even benzodiazepine withdrawals. But prolonged sedation and accumulation can occur with long duration of benzodiazepine treatment, and it promotes delirium. So what are all the drugs we previously used? Lorazepam, midazolam. Coming to lorazepam, it acts at brain and spinal cord. It has a loading dose of 0.04 milligram per kg. Onset of action is immediately within 1 to 5. The duration is 6 to 10 hours. Infusion of 0.1 milligram per kg per hour. And it is metabolized in liver. It has no active metabolites. Midazolam is highly lipid soluble. It has a loading dose of 0.05 to 0.1 milligram per kg. Onset is 1 to 2 minutes. Peak is within 2 to 5 minutes. Duration is 1 to 2 hours. It has an infusion dose of 0.1 milligram per kg per hour. It is usually metabolized in liver. It has an active metabolite, which is 1-hydroxymidazolam. It is excreted by kidney. So what are the adverse effects? The major one is the prolonged sedation. After long-term use of benzodiazepines, it delays awakening, it may delay weaning and prolong ICU stay. So more in midazolam than lorazepam because of the lipid solubility. It can cause delirium due to effect on the GABA receptors. Drugs which produce sedation without involvement of GABA receptor do not produce delirium. And withdrawal symptoms like abrupt stoppage of infusion can lead to this withdrawal, agitation, disorientation, seizures also can happen, but it is not very common. We should know something about propylene glycol toxicity. Lorazepam contains propylene glycol to enhance the solubility in plasma. It is converted to lactic acid in liver. So excess use will cause metabolic acidosis, hypotension, delirium, multi-organ failure. 1 milligram of 1 ml of lorazepam contains around 850 milligram of propylene glycol. So maximum daily intake is 17.5 gram. So Lora infusion should not be continued for more than 24 hours. If the dose is 2 milligram per hour. How to diagnose the propylene glycol toxicity? If there is a high lactate levels and high osmolar gap. So antidote of benzodiazepines is flumazenil. It binds to receptor, effective in reversing the sedative effect of benzodiazepines, but no respiratory depression. The dose is bolus of 0.2 milligram repeatedly after 5 minutes up to 1 million. So 5 doses can be given repeatedly. Effect lasts for 1 hour. So you have to start infusion for the prolongation of the flumazenil effect. What are all the adverse effects? Withdrawal symptoms can occur and even seizures can occur because it decreases the benzodiazepine activity. Propofol is the agent. It is a powerful sedative. It acts by binding to GABA receptors. It has a sedative and amnestic effect, but no analgesic effect. It is highly lipophilic. It is suspended in 10% emulsion to enhance the solubility. No dose adjustment is required in renal or hepatic impairment. So loading dose is 1 to 2 milligram to 1 to 2.5 milligram per kg. Onset is 1 minute. Peak action is around 1 to 2 minutes. Time to result is 10 to 15 minutes. Maintenance dose of 50 to 150 miles per kg per minute. It has an adverse effect of hypotension, respiratory depression, hyperlipidemia, and you should know about propofol infusion syndrome. When the patient gets 4 to 5 milligram per kg per hour for at least 2 days, this dose may lead to propofol infusion syndrome, which presents as bradycardia, metabolic acidosis, rhabdomyolysis, renal failure. Coming to dexmedetomidine. It is alpha-2 receptor agonist. It has sedative effect, amnestic effect, and mild analgesic effect also. It produces cooperative sedation or conscious sedation. The patient can be aroused from sedation during drug infusion. Patient can follow commands and communicate in the interim period. It acts similar to the natural sleep pattern. So the loading dose is 1 mic per kg over 10 minutes. Onset is around 5 to 10 minutes. Time to arousal is 6 to 10 minutes. Maintenance dose is 0.3 to 0.7 microgram per kg per hour. No, it has no respiratory depression. And it is useful in patients of ICU acquired delirium also. What are all the adverse effects? It can cause hypotension, bradycardia, sympathetic rebound. It should be avoided in heart failure and patient having conduction abnormalities. So what is the choice of sedative? Recommendations of PADILs are propofol should be given over benzodiazepine for sedation in mechanical ventilated patient after cardiac surgery. Use of either propofol or dexmedetomidine over benzodiazepine for sedation in critically mechanically ventilated patients. There are few trials which we should know. One was Midex Prodex trial, where there is it is a non-inferiority trial where dexmedetomidine is comparable with midazolam and propofol in terms of shorter duration of mechanical ventilation and decrease in the incidence of delirium. Then came MEDS 2 trial, where similar efficacy of propofol and dexam was seen in patient in regard with mortality, acute brain dysfunction, that is delirium, or days of mechanical ventilation. The recent trial was SPICE 3 trial, where dexam use resulted in early extubation, less delirium, but definitely it was associated with significant side effects like bradycardia and hypotension. So coming to delirium. Delirium is very common in ICU patients, as we see often. There are three types: hypoactive, hyperactive, mixed. Mixed delirium is most common at around 60%, followed by hypoactive, followed by hyperactive delirium. So how to assess delirium? It is a CAM ICU score, confusional assessment method for the ICU flow sheet. There are four components. First is acute change or fluctuation of mental status within 24 hours. Is there an acute change from mental status, or has the patient's mental status fluctuated during the past 24 hours? If it is no, then CAM-ICU is negative, no delirium. If it is yes, then you have to see the attention of the patient. If the patient is inattentive, means patient is not able to follow proper comment, then you have to see the score. If there are more than 2 errors, then you have to go to the next step. If there is less than 2 errors, then CAM-ICU score is negative. There is no delirium. If the patient has acute change in meditation followed by inattention, and in inattention the error is more than 2, then you have to see the level of consciousness. Even you have to see the RAS level or sedation level. If the RAS score is less than 0, other than 0, then KMICU is positive. No need to go to the fourth step. If the RAS is 0, then you have to go to the fourth step, that is disorganized thinking. You have to ask questions and listen to the answers. If there is a more than 1 error, then KMICU score is positive. And if there is a less than 1 error or 0 error, then KMICU score is negative. So the score, if it is more than 3, then definitely delirium is present in this patient. So how to prevent? Most important thing is prevention. No pharmacological agent is approved for the prevention of delirium. Treatment recommendations in PADIS guidelines is haloperidol or atypical antipsychotics can be used, but should not be used routinely. And haloperidol should be used mostly in hyperactive delirium. You have to avoid the preventable causes. And anxiety, fearfulness, hallucination, delusion, agitation, harmfulness to others. These patients can benefit from short-term use of these drugs until distressing symptoms resolves. So mostly symptomatic treatment and reversal of the disease and facilitating the things that the patient likes will help in decreasing the delirium. So this is a flow chart we can use for any patient. First, we have to assess and treat pain. It is a multimodal approach to treat pain. Is the pain well controlled? Yes. There is a therapeutic indication of sedation. If the pain is actually controlled, then there should not be a indication of sedation, because what we are practicing nowadays is analgo sedation. First to address analgesia, then sedation. If there is a therapeutic indication of sedation, if it is yes, then use specific therapeutic drugs like barbiturates or epileptics for status epilepticus. Consider propofol or dexmedetomidine to achieve sedation target of whatever the target you want to achieve, 2 to 3 or whatever. And then review the current conscious state and sedation levels, whether the patient is agitated or target sedation score is achieved or over sedated. Means RAS score is +1, RAS score is -1 to +1, or over sedated at -2. Is sedation required for safety? Yes. Means if the delirious patient and the patient who is doing harm to the medical staffs, then you have to escalate. And you can use propofol or dexmedetomidine. If the sedation required for safety is not required, then no additional sedation you should use. And if the target sedation score is -1 to +1, then you have to see for the delirium. If CAM-ICU score is positive, then you have to correct the underlying cause, and you have to seize the offending agents. And non-pharmacological measures also can be used. And if CAM-ICU score is negative, continue reassessment, and we should again go to the top of the chart to see whether the patient is having adequate pain control. And if patient is over sedated, RAS score less than -2, then you have to de-escalate the. You have to seize the measure. Win of the sedation, use low dose alternatives, and you have to review the cause of over sedation. So this is a chart showing pain control by doing early recognition of pain, assessment of the pain, and treatment of pain, then optimal sedation, with a multimodal approach, then prevention of delirium by anticipating early, recognizing the delirium early, and managing properly, which will lead to shorter duration of ventilation, early mobility, and cognitive well-being. Thank you.
Thank you, Abhilash sir. Now we will move to our next session. The next session will be taken by Dr. Rupali Patnaik ma'am, and the topic is feeding and nutrition, assessment and designing nutrition plan, and the ISCCM guidelines on the nutrition in ICU. I welcome you, ma'am, to please proceed with the.
Is it visible on screen?
Yes, ma'am.
Yeah. Good afternoon, everybody. I'll be talking on nutritional management in ICU. This is my outline of the talk, important definitions related to nutritional therapy in ICU. And what is the importance of nutrition in ICU? What are the recent guidelines say? These are basically the European Society Guideline 2019, the American Society of Enteral Parental Nutrition Aspen Guideline 2016, and there's an update of Aspen Guideline in 2021. Okay, I'll focus on this update of Aspen 2021 and not going much to ISCCM guideline because it is before it came around 2018. And after that, most of the things have been updated, which is recent is this Aspen 2021 update. Okay, published in journal Enteral and Parental Nutrition. Then I'll talk on nutritional risk assessment, enteral and parental nutrition. Nutrition in specially clinical situations of ICU like septic shock and ARD, and the update on Aspen guideline. Important definitions. What is standard therapy? It is provision of IV fluid, no enteral or parenteral. Then after stopping the IV fluid, advancement to oral diet is tolerated. What is medical nutrition therapy? It is provision of either enteral nutrition or parenteral nutrition and or supplemental oral. This is called medical nutrition therapy. So our focus is on medical nutrition therapy. Isocaloric diet, it is energy administration of around defined target. Hypocaloric or underfeeding is when energy administration is less than 70% of the defined target. Overfeeding, when energy administered is more than 100% of the defined target. What is low protein diet? It is when protein administration is less than 0.5 gram per kg per day. And trophic feeding is minimal administration of nutrients having beneficial effect on enteral nutrition. They are the clinical guidelines, Aspen 2016 and Aspen 2019. It was the diagnostic tree for malnutrition. At risk for malnutrition is these patients because of disease-related malnutrition with inflammation, or disease-related malnutrition without inflammation, or malnutrition or undernutrition without any disease. So our focus is this one, the disease-related malnutrition with inflammation, which is acute disease or injury-related malnutrition, where the critical illness sets in. And others is like chronic disease-related malnutrition with inflammation, like cancer, cachexia, and other specific cachexia condition. But critical illness sits here. Why the critical ill patients are at risk? These are ICU patients are in acute stress. They have pre-existing malnutrition. Up to 40% of these patients who are getting admitted to ICU have pre-existing malnutrition. And there is altered metabolic pathway in critical illness. What are they? These are like shift from anabolic state to catabolic state, gluconeogenesis increase, glucose intolerance, and there is insulin resistance, increased oxygen consumption, and cytokine release. These are the various altered metabolic pathway in critical ill patients. So these patients are at high risk. Coming to phases of critical illness, there are 3 phases. One is like acute phase, which is early period within 1 to 2 days of admission to ICU or critical illness. Then late period is the acute phase is early period 1 to 2 days. Then day 3 to day 7 is the late period of acute phase. This is the phase of catabolism. This is up to 7 days, the most important is the phase of catabolism. So for this 7 days, this past 7 days of critical illness or admission is most important to think for proper nutritional therapies. Then after 7 days, there comes the anabolism phase, or when the recovery phase or rehabilitation phase. So we have to think for medical nutrition therapy appropriately for all patients at ICU as early as possible. What are our goals for nutrition in ICU? It's to preserve the lean body mass, provide substrate for metabolic function, modify the stress response, improve immune function, and prevent the metabolic complications. These are the main goals why we have to think for early nutrition in ICU. There are various ways of assessment of nutritional status, like to ask for detailed history with functional status assessment, the pre-existing nutritional status. Then physical examination and various anthropometric measurements. Biochemical and laboratory tests, like various parameters like albumin, retinol, the various parameters are there pre-albumin. I'm not going in detail of each of these. We have to go through each. Okay. These are the main overviews like history, functional status, nutritional previous nutritional status, anthropometric measurements, biochemical and lab tests, and most important, newly evolving is the ultrasound for nutritional assessment. Okay. These are the assessment tools for nutrition. Then various screening tools for assessment. Various screening tools are there like Nutrix risk screening 2002, NRS 2002, it came in 2002. Other is Nutrix score. Others are subjective global assessment, malnutrition universal screening tool, MUST, short nutritional assessment questionnaire, and malnutrition screening tool, MST. These are the various screening tools available. Not only people must be aware of Nutrix score and NRS, but these are the other tools available for assessment of nutrition. These are the screening tools. I've kept here the NRS and the Nutrix score. Nutrix score everyone must be aware of. It includes age, Apache 2 score, SOFA, number of comorbidities, days from hospital to ICU admission, and the interleukin 2 level if it is available. If it is interleukin 6 level if available. If it is not there, then 5 parameters are taken into consideration. Then Nutri-Score, if interleukin 6, most of the places it is not available, so we have to think this one. If score is more than 5, then they are high risk for malnutrition with the critical illness. They are associated with worse clinical outcome, increased mortality, increased ventilator days, and these patients are most likely to benefit from aggressive nutritional therapy. If we are getting a patient with higher Nutrix score more than 5, then we have to aggressively think for proper nutritional therapy. Okay, early and aggressive nutritional therapy for these patients. If they are low risk, then they are low risk for malnutrition risk. Then NRS is also there. It is comprises various parameters. Then like 2 steps. One is initial screening, then final screening. Various parameters are there. Then if score is more than or equal to 3, then patients at high risk for nutrition, then think for proper nutritional assessment. These parameters determine both nutritional status and disease severity. So this NRS and Nutri-Score is very much important for the critical care point of view compared to other ones. Then determination of energy need. Okay, various steps are there. We have to calculate the resting energy expenditure or basal energy expenditure. It is the heat production by basal metabolism in the resting state and fasting state. Then determine the activity or injury factor and calculate the total energy expenditure, which is the basal energy expenditure multiplied by the activity factor and the injury factor. Okay. The activity factor and injury factor, various charts are there for various diseases like critical illness, burn, everything. Various different digits are there. Okay. Then what is the for energy need calculation? The gold standard is the indirect calorimetry, and we don't have, most of the places are not having indirect calorimetry, which is the gold standard. Then predictive equations follow, but these predictive equations have poor accuracy. One must be aware of Herrick's-Benedict equation. This is the conversion equation, or simple is when nothing is there with our hand is the weight-based equation to calculate the kilocalorie per kg per day. This 25 kilocalorie per kg per day. Role of nutrition is oral diet obviously preferred over enteral or parenteral is patient is able to eat. If oral intake is not possible, then early enteral nutrition within 24 hours to 48 hours should be performed rather than delaying the enteral nutrition. The first is early enteral. If you have to think for early enteral nutrition, early enteral nutrition should be performed the early parenteral nutrition. And in case of contraindication to oral or enteral nutrition, their parenteral nutrition should be implemented within 3 to 7 days of ICU stay. Okay, if enteral nutrition is not feasible, then we have to early parenteral is definitely advised there. It is obviously within 3 days is most important. If it is not possible for enteral, then go for parenteral. It's be early, no issues. Then to avoid overfeeding, early full enteral or parenteral nutrition should not be used but prescribed within 3 to 7 days. Okay, it's like gradually you escalate so that within 3 to 7 days, whole of the calories be achieved. This is to avoid overfeeding. Obviously, routes of nutrition, if our GI tract is functional, then should prefer the enteral nutrition. Enteral nutrition by standard nutrition specialized formulas. If GI tract is non-functional, then we should think for early parenteral nutrition. What are the conditions? It's like patients with short bowel syndrome, GI surgeries, most of the bowel have been rejected, and like patients with high output fistulas, there obviously enteral nutrition is not feasible. If patients are intolerant to enteral nutrition, then you should not start delay parenteral nutrition, start full-fledged parenteral nutrition early there. Okay. Sorry. Why enteral nutrition is preferred? It is like to maintain the GI tract structure, integrity, and function. It is easier and more physiological, obviously, and enhances intestinal immune function like secretory IgA, and reduces the bacterial translocation and sepsis. Fewer complications than parenteral. Obviously, parenteral is associated with various complications like line-related complications. It's like we have to their line complication most important. Others like liver dysfunction, hypertriglyceridemia, hyperglycemia. These are the various complications of parenteral nutrition. So fewer complications than the parenteral, obviously, and obvious it is very less expensive compared to parenteral nutrition. These are the various advantages of enteral nutrition, and it should be preferred over parenteral nutrition when it is feasible. What are the advantages of early enteral? Okay, not going into detail. There are the various studies with meta-analysis which has come with results that early enteral nutrition is obviously associated with the mortality benefit. See, here it is, it favors the early enteral nutrition, the forest plot. And early enteral nutrition is associated with less infectious complications. Less infectious complication, it favors the early enteral nutrition. Enteral nutrition feasible, obviously enteral is preferred over parenteral, less mortality benefit is there, and infectious complications are less. Then early enteral versus early parenteral. Obviously, early enteral nutrition is associated with less infectious complications compared to early parenteral nutrition. These are including both ICU patients and non-ICU patients also. Then comes the protein requirement. Protein is the building block of the body. 1 gram of protein contains 4 kilocalories. On degradation of 6.25 gram protein, 1 gram of nitrogen. Okay, protein prevent protein breakdown and maintains the positive nitrogen balance. Okay, so what is our main protein requirement is to maintain the positive nitrogen balance, so that enough NPC is mandatory. We have to give the non-protein calories enough. Otherwise, everything is lost from the protein only. Daily energy requirement is NPC from the carbohydrate and lipids, like 70% of carbohydrates and 30% from lipids should be. This is the protein requirement chart. Most things is the 1.2 to 2 gram per kg per day. This is the our protein requirement. 1.2 to 2 gram per kg per actual body weight. And patients with dialysis, basically, they need very high amount of protein. They require almost like 2.5 gram per kg per day. This is very most commonly missed, and these patients are being on catabolic state because of we are not giving adequate protein. So think that patients with dialysis, they should get almost like 2.5 gram per kg per day. This is the high requirement of proteins. Others like 1.2 to 2 gram per kg per day is to give the protein supplementation. Then comes the enteral nutrition dosing. Enteral nutrition, glucose, protein, and fat. Glucose is minimum 20% of NPC. It is like 2 gram per kg per day. or and each gram contains 4.1 kilocalorie. Fat should consist maximum of 80% of the NPC, and 2 gram per kg per day is the requirement, with 1 gram contains almost 9 kilocalorie. NPCs from glucose to fat ratio should be 60 to 40 or 70 to 30. Protein requirement 1.2 to 2 gram per actual body weight per day. The calorie density of the enteral nutrition should be 1 to 2 kilocalorie per ml of feeding solution, not more than 2. Okay, we are basically should give the isocaloric feeding like 1 kilocalorie per ml. Now, and water is volume requirement 30 to 40 ml per kg per day, or unless there is water restriction, this should be the feeding enteral nutrition contains should this much amount should be there. Then feeding regimen, estimate the daily calorie and protein requirement. The calories like 25 kilocalorie per kg and protein is 1.2 to 2 gram per kg per day. Then we have to select the feeding formula and calculate the infusion rate. We give the infusion feed, then feeding volume is the kilocalorie requirement divided by kilocalorie per ml in feeding formula, because each the feeding formulas usually contain 1 kilocalorie per ml. We'll divide, then give the ml of the feeding volume for 24 hours, and for rate per hour, then we have to divide by the hour. So feeding per hour, if we are getting the, if we are giving the continuous feed. Then protein intake is for 1.2 to 2 gram per kg per day, and we have to adjust the feeding volume accordingly. Then tolerance to enteral nutrition. Okay, avoid inappropriate suggestion of enteral nutrition. This is most important. Okay, minimize the NPO time for diagnostic tests and procedures. Okay, like for tracheostomy, for any bronchoscopy, anything. Then we have to minimize the NPO time so that the timing should be adjusted properly with the procedures. And GRV should not be used as a part of routine to monitor feeding tolerance. Do not hold enteral nutrition for GRV less than 500 ml. If it is less than 500 ml per day, then also you continue the enteral nutrition. And if there is diarrhea, then you should not interrupt enteral nutrition due to diarrhea. With the evaluation of the diarrhea, continue the enteral nutrition. Then coming to root of enteral nutrition tolerance, intolerance to bolus or gastric enteral nutrition. If these patients are not tolerating the gastric enteral nutrition, we have to switch to continuous infusion. Try for the infusion feed if bolus feed is not being tolerated. Or we can divert the level of feeding to post-pyloric enteral SSS. These are like nasojejunal tubes feedings, everything. And can consider the prokinetic use whenever it is feasible. This is the meta-analysis of feeding tolerance of post-pyloric versus gastric feeding. There, the tolerance is more favors the post-pyloric feed. See, here the meta-analysis of feeding tolerance in patients with gastric or post-pyloric feed. The tolerance is more with the obviously a post-pyloric feed, but there is no outcome benefit with the nasojejunal tube, like incidence of pneumonia, mortality benefit, or these aspects are similar with the NJ or NG, nasojejunal or nasogastric feeding. Only is the tolerance is better compared to the nasogastric feeding there in the post-pyloric SS. Coming to specialized enteral nutrition. These are various specialized nutritions are very much advertised these days. What we have to think, what are the guidelines are telling? You should not routinely use immune modulating enteral formulas. Okay, in medical ICU settings like arginine, glutamine, EPA, and DHA. Okay, these can be considered in traumatic brain injury patients and perio patients in the surgical intensive care unit. Obviously, there is role of arginine, glutamine, and DHA. Okay. And EPA, these can be used in surgical ICUs and traumatic brain injury patients, but not for the medical ICU patient. There are no recommendations for enteral formulation with anti-inflammatory lipid profiles like omega-3 fatty acids. These are no recommendations to add these lipids to enteral nutrition for anti-inflammatory properties. And combination of antioxidant, vitamins, and trace minerals in doses reported to be safe in critical patients should be provided, like less than 5 to 10 times of RDA, antioxidants or vitamins or trace minerals, not in overdoses. These high dose monotherapy should not be administered without proven deficiency also. Antioxidant, there is obvious deficiency, then you supplement. Otherwise, there is no role in to start in all patients. Then specialized enteral nutrition with glutamine versus no glutamine. There is no mortality benefit or in obviously mixed ICUs and but in trauma and SICU, there is and bond also there is some favor with the enteral nutrition with glutamate here. But in medical surgical ICU, mixed ICU, there is no benefit. Then where we should not fear for enteral nutrition, cases with severe acute pancreatitis, most important. Always prefer enteral nutrition. Okay, if it is not being tolerated the gastric feeding, then change to post pylori cases. But try for enteral nutrition whenever it is feasible. Try for enteral nutrition only. After GI or esophageal surgery, then also think for enteral nutrition. Patients with abdominal trauma, when continuity of the GI tract is confirmed or restored, okay, after GI tract continuity is restored, if there is injury or there is confirmed that no breach or no breach in the GI tract continuity, then should start enteral nutrition. Patients in prone position, patients with open abdomen, unless there is bowel ischemia or obstruction suspected in diarrhea, patients with diarrhea, unless there is bowel ischemia or unless there is any obstruction, then think for and then start enteral nutrition only. Patients with IH, intra-abdominal hypertension, without abdominal compartment syndrome with vigilance. Patients with intra-abdominal hypertension, but they are not in abdominal compartment syndrome, then also you can start, you can think for enteral nutrition, even trophic feeding, but enteral should be maintained. And but this is with vigilance, with the tolerance and everything, and at least start the trophic feeding, 20 to 30 ml per hour of infusion feed. Cases where enteral nutrition can be delayed. It's most important, patients with shock with uncontrolled hypertension and escalating doses of vasopressors. Obviously, need of vasopressor not at all a contraindication for starting the enteral nutrition or continuing the enteral nutrition. It is the shock when there is uncontrolled hypertension with escalating doses of vasopressors. There you can think for delaying the enteral nutrition. And patients with hemodynamic and tissue perfusion goals, they are not reached despite resuscitation. Despite resuscitation, hemodynamics and perfusion not being achieved, then you can delay some enteral nutrition. But we can consider trophic feeding there. Yep. These are the cases like active upper GI bleed, patients with overt bowel ischemia, high output intestinal fistulas if reliable distal feeding SS is not achievable, and patients with abdominal compartment syndrome. There, to maintain the GI tract continuity, you can start, consider trophic feeding here. Then comes the parenteral nutrition. This is the process of supplying nutrients by the IV route, total parenteral nutrition, and peripheral parenteral nutrition. Peripheral through peripheral line, and this is through central line. Osmolality limits are peripheral is for 600 to 900 milliosmoles per liter, and central is 1800 milliosmoles per liter. The commercial available parenteral nutrition and compounded parenteral nutrition administers are they are same, and their osmolality is for that both TPN and PPN comes. The regimen like parenteral nutrition, dextrose solution is like 25% dextrose or 50% dextrose. Hyperosmolar ones, obviously we have to prefer the central line for the total parenteral nutrition. And they have the amino acid solution, 7 to 10% of the amino acids are there. It's a mixture of essential to non-essential amino acids, almost 50 to 50. They have the lipid solutions, like 10 to 20% of the lipid. They can use through the peripheral line also lipid. And electrolyte or micronutrients and monitor for refeeding syndrome. The most important with the parenteral nutrition. If there are high chances of electrolyte abnormalities, micronutrient deficiency, and refeeding syndrome with the parenteral nutrition. There is hypophosphatemia and refeeding. The partial parenteral nutrition, like dextrose is less there, 10 to 20% of the dextrose, because of osmolality, you have to keep your loan through the peripheral line, it has to go. That's why. And like 1.5 to 3% of the amino acids and 10 to 20% of the lipids. The parenteral nutrition should not be started until all strategies to maximize enteral nutrition tolerance is most important. And supplemental parenteral nutrition should start after 7 to 10 days, irrespective of nutrition risk. Supplemental parenteral nutrition, if unable to meet 60% of the target by enteral nutrition, that you have to maximize, start enteral only fast, maximize enteral nutrition tolerance, then also think for parenteral nutrition by 7 days. And supplemental parenteral nutrition, we are unable to make the 60% of the energy target by enteral nutrition, then think for supplemental parenteral nutrition. That is also by day 7 only. Supplemental parenteral nutrition prior to 7 to 10 days, there is no improvement, but even it is detrimental. Okay? So supplemental parenteral nutrition prior to 7 days is not required. Do not use routinely the parenteral glutamine. Enteral versus parenteral nutrition charts. This is enteral nutrition obviously simpler, cheaper, fewer complication, maintain GI function, avoids TPN and its complication. The advantage like rise to and its complication, there is risk of pneumonia and microaspiration and intolerance. Parenteral nutrition, no depends on gastric or intestinal function, less need for interruption. It's always start, it continues goes, and better attainment of nutrition goals. But catheter-related complication, sepsis, line sepsis, occlusion, hyperglycemia, hyperchloremic metabolic acidosis, and electrolyte abnormalities. Most common is the hypophosphatemia, hypokalemia, and refeeding syndrome, hypercholesterolemia, hypertriglyceridemia, most important, and liver dysfunction, cholestasis due to parenteral nutrition. They are the various disadvantages of parenteral nutrition. Then micronutrients. The micronutrients like vitamins, ADK, both soluble and vitamin B, biotin, folate, and the trace element should be supplemented as per the need, like chromium, copper, iodine, manganese, selenium, and zinc. Electrolytes and their requirement per kg per day. Sodium, potassium, it's almost like 1 millimole per kg per day requirement. And calcium, magnesium is 0.1 and phosphorus 0.4 millimole per kg per day. Water is 30 to 40 ml per kg per day. So we have to think for our enteral nutrition and requirement is for that. When it comes to nutrition in special situations, I focus on septic shock and ARDS only. Septic shock, they start enteral nutrition within 24 to 48 hours as soon as resuscitation is complete. Do not use exclusive supplemental parenteral nutrition in acute phase of sepsis or septic shock. Trophic feeding 10 to 20 kilocalorie per hour up to 500 kilocalorie per day. This is the definition of trophic feed. For initial phase of sepsis or septic shock with escalating dose of vasopressor, then think for trophic feeding. And advancing age tolerance after 24 to 48 hours. Up to 48 hours, you think, then advance gradually by 48 hours to reach 80% of the goal over the first week. And 1.2 to 2 gram per kg per day of protein requirement. And we should not routinely use immune modulating enteral formulas. Acute respiratory failure, high fat, low carbohydrate formulas, as was being previously very much encouraged, this should be avoided. There is no role. Consider volume restricted formulas, obviously, patients with ARDS, and we have to monitor serum phosphate level and replace age appropriate. Chronic critically ill with persistent organ dysfunction, ICU length of stay very high, more than 21 days. Then aggressive high protein enteral nutrition therapy and active exercise rehabilitation is very much important there. And this is some update of the Aspen guideline, came in 2021, published in Journal of Enteral and Parenteral Nutrition. 5 things they've updated. Just let me tell one by one. This is in adults critically ill patient, does provision of higher versus lower energy intake impact clinical outcome? There is no significant difference in clinical outcome between patients with higher versus lower level of energy intake. So they suggest feeding between 12 to 25 kilocalorie per kg. Okay, as it was like 25 to 30 before, they've decreased it to 12 to 25 kilocalorie per kg in the range of mean energy intake. In the first 7 to 10 days of ICU stay, 12 to 25 kilocalorie per kg per day is important. Then second question is, in adult critical patient, does provision of higher as compared with lower protein intake impact the clinical outcome? There was no difference in clinical outcome or relatively limited data because of positive trials with high quality of evidence cannot make new recommendation at this time beyond 2016 guideline, and obviously suggestions as before like 1.2 to 2 gram per kg per day. Then question 3 is, in adult critical ill patients who are candidates for enteral nutrition, does similar energy intake by parenteral versus enteral is the primary feeding modality in first week of critical illness impact clinical outcome? Very important question. Candidates, they are candidates for enteral nutrition, but similar energy intake what we have is early enteral. This is like early enteral versus early parenteral. So here there is no significant difference in clinical outcomes because similar energy intake provided as parenteral nutrition is not superior to enteral nutrition and no difference in harm were identified. They are recommending either parenteral or enteral nutrition as per acceptance. Okay. Then here like more of the studies are coming with early parenteral. There they are telling you either you can use, but obviously enteral nutrition is preferred. Here, like cost and convenience of providing enteral nutrition versus parenteral may be larger determinant of route of feeding in early critical illness than difference in clinical outcome. This is more important. The not important are the clinical outcome. Most important is the convenience and the cost of providing enteral nutrition. And parenteral nutrition use arises when enteral nutrition is not feasible or tolerated in patients significant diseases who were not the population studied in this question. Okay. Here they didn't study for patients where enteral nutrition is not feasible, like patients with higher fistula, short bowel syndrome, major resection of the GI tract. These patients were not included for the trials here. It is like normal critical ill patients. That's why, but it is the cost and convenience is more important in critical ill patient compared to the clinical outcome. That's why obviously early enteral is preferred over the early parenteral. Then question number 4, in adult critical patients receiving enteral nutrition, does provision of supplemental enteral nutrition compared with no supplemental parenteral nutrition during first week of critical illness impact the clinical outcome? So there is no significant difference in clinical outcomes. Within 7 days, I told before also, this like within 7 days, there is no role of supplemental parenteral nutrition. Based on findings of no critically important benefit in providing supplemental parenteral nutrition early in ICU admission, they are recommending not initiating supplemental parenteral nutrition prior to day 7 of ICU admission. Okay. Then question number 5, like in adult critical ill patients receiving parenteral nutrition, does provision of mixed oil mixtures like medium triglyceride, olive oil, fatty acid, and mixture of oils as compared to soybean oil. Okay, most of the parenteral nutrition solutions are soya oil. They impact the clinical outcomes. It is like they suggest that either mixed oil or 100% soybean oil can be provided in critical patients who are appropriate candidates for initiation of parenteral nutrition, including within the first week of ICU admission. Both are same. Then adults, critical ill patients receiving parenteral nutrition, who are for parenteral nutrition, the provision for fatty acid oxidase containing oil mixture, they impact the clinical outcome. This is like both are same. They are recommending because there is only one outcome found. There is no significant difference between the two. Key messages: acute planning of optional nutritional support, integrated approach, route, timing, and calorie protein target to get prevent and detect any possible complications of nutritional therapy. You have to monitor response to feeding and detect or treat refeeding. This is most important. Monitor response and detect and treat refeeding also. Detect and treat micronutrient deficiencies and maintain normoglycemia. And most important are the electrolyte imbalances. Thank you.
Thank you, ma'am. Next, I will like to invite Dr. Sanjeev Dar sir. Sir will be dealing with another important topic, that is blood pressure, ETCO2, and also cardiac output monitoring in ICU. Over to you, sir.
Is it audible, Shajan?
Yes, sir.
Okay. Good evening, everyone. I am presenting the next topic, the blood pressure, the cardiac output, and ETCO2 monitoring. These are the three parameters we'll discuss now. So, blood pressure, the blood pressure, how we usually calculate, this is the arterial blood pressure is the product of the cardiac output and systolic vascular resistance. So, blood pressure that usually we measure, there are two types, non-invasive one and the invasive one. And non-invasive, I am not going for that we measure by the sphygmomanometer that we do in OPD basis. And another non-invasive one that we do with our monitor. And And the invasive one, that is we put our one arterial line and we measure continuously, that invasive blood pressure monitoring. So in non-invasive, so the COP measures the point of maximum oscillation and that correction of the mean atrial pressure, and from the mean atrial pressure, the oscillation begins above the systolic blood pressure and continues below the diastolic blood pressure, and from this that calculates the systolic and diastolic blood pressure. This again non-invasive one, invasive that we measure by putting an arterial line. So here the principle is that the transducer convert the pressure signal that transmitted from the arterial pressure through the diaphragm. So that pressure signal changes to electrical signal, and this electrical signal again modified to waveform by the monitor. So this is basically based on the dynamic response. What is the dynamic response? Dynamic response is the ability of the fluid field system to accurately reproduce the patient's hemodynamic waveform. So this hemodynamic response the main stem for the arterial blood pressure, invasive arterial blood pressure monitoring. So this dynamic response is basically based on the two things, two features: the resonant frequency and the damping coefficient. So resonant frequency is the frequency at which it oscillates when the fluid field system oscillates when it is stimulated. So the resonant frequency should be much higher than the natural frequency of the patient arterial pressure. So resonant frequency of the system must be greater than the highest frequency of the incoming signal, that is the pressure signal from the patient artery. So if you see one heart rate of 60 beats per minute, it corresponds to approximately 1 hertz. Similarly, up to 120 beats per minute, that corresponds around to 2 hertz. So our resonating frequency should be at least 20 hertz, 20 times, 10 times, 10 times for the patient's frequency, patient's highest frequency. So 2 hertz patient's frequency, if that corresponds to 120 beats per minute. So at least 20 hertz should be there, the resonating frequency of the system to accurately reproduce the pressure waveform. Similarly, damping coefficient, this refers to the how quickly the oscillating fluid field system come to rest. So a system with high damping coefficient that diminishes the waveform, that dampens the waveform very quickly, and a low damping coefficient that dampens improperly, then that gives rise to overshooting of the systolic blood pressure and diastolic overshoot also. So for arterial blood pressure monitoring, these two features must be there. So from the invasive arterial blood pressure monitoring, we have what parameters we derive the pulse pressure variation. I am not going in detail through these things. So pulse pressure variation, you know that is a variation is more than 13%, then your fluid responsiveness, and similarly the stroke volume variation, stroke pressure variation, all these things. So I'm not the indication of the invasive pressure monitoring when there is severe hypertension or use of rapid acting vasoactive drugs or vasodilator, when use the vasopressor or inotrops, or frequenting sampling of arterial blood pressure, like when patient is having on a ventilator. So in these patients we usually put a arterial line. And the relative indications are also the severe hypertension, presence of intra-aortic valve pump, essentially unreliable or difficult to obtain, or non-invasive blood pressure monitoring. So these are the blood pressure monitoring system. Coming to cardiac output monitoring. So cardiac output, there are different cardiac output monitoring system classified depending on the invasiveness. So invasive, the most invasiveness one is the pulmonary catheter, and secondly, the semi-invasive one is the there are 3-4 devices. There are transpulmonary thermodilation technique and lithium dilation technique, pulse wave analysis. Again, in pulse wave analysis, there are 3 to 4 devices, and isovagal Doppler ultrasound. Similarly, in non-invasive technique, we have the bioreactance by impedance, thoracic continuous Doppler ultrasonography, non-invasive atrial waveform analysis, and echocardiography. Here we see the waveform analysis. In waveform analysis, we have both the semi-invasive one and the non-invasive one. In semi-invasive one, we put line inside the artery, and we recognize the arterial, analyze the arterial waveform. But in non-invasive one, we don't have to put any catheter inside the artery, but we analyze the pressure over the artery. So this is a non-invasive one. So I'll go in detail. So these are different methods of monitoring cardiac output, and these are the different systems. So this is the pulmonary thermodilation technique. This is cardiac output. By this technique, we measure the cardiac output by the pulmonary catheter. So pulmonary catheter measure the cardiac output by pulmonary thermodilation technique. Again, this is different one. The transpulmonary thermodilation technique. This is the PICO method. This is measuring the cardiac output. Here, I'll go in detail later on about this one. So here we inject the saline some cold saline inside through the our central vein, and we measure the temperature in the arterial system, axillary artery, femoral artery, and measure the temperature difference. So this is known as the transpulmonary thermodilation technique. But here, instead of a distal artery of in pulmonary thermodilation technique, instead of measuring the temperature inside the pulmonary artery, instead of measuring the temperature inside the axillary or femoral artery, here in pulmonary thermodilation technique, we measure the temperature changes in the pulmonary artery. So these are a bit confusing, but different technique. So transpulmonary, again, indicator direction technique that we use the LITCO system, and arterial pulse waveform. These are again the PICO, LITCO. These are single parameter. This, by arterial waveform analysis, they can give also continuous cardiac output monitoring also. So other arterial waveform analysis are flow track visual system, and esophageal Doppler, and thoracic echography that we do by velocity time integral, and fixed principle, and bioimpedance by reactance. We'll go in detail. So invasive pulmonary catheter, I'm not going in detail because subsequently you have the classes. So in pulmonary catheter, we put some saline at room temperature into right atrium, and that that goes through right atrium, right ventricle into the pulmonary artery. And so here we inject some saline at a room temperature, so that we measure temperature difference in the pulmonary artery. Temperature difference in the pulmonary artery, and this temperature difference is again calculated by one equation that is known as Hamilton principle. So with the area under this curve is calculated as the cardiac output through this Stewart-Hamilton principle. So by this pulmonary catheter, we can get a single cardiac output measurement. We can get also continuous cardiac output monitor also. In continuous cardiac output system, in pulmonary catheter, we have a thermal filament that warm the blood inside the superior vena cava. And the change in temperature is measured at the pulmonary catheter tip. The sensor is at the tip of the pulmonary catheter. The temperature difference is measured there inside the pulmonary artery. So a discrete value that represents the average of value over the previous 60 to 120 section, rather than a bit to bit variation or a minute to minute measurement. So that give you a measurement over 60 to 120 seconds. So filament, that heating filament remain inside the superior vena cava, and the measuring filament remain inside the pulmonary artery at the tip of the pulmonary catheter. And the start module give one a single value measurement. So these are the only invasive method. Semi-invasive method, we have the transpulmonary thermodilation technique, LITCO, the lithium dilation technique, and the pulse wave analysis. There are different systems are Pro Acuity, LITCO Rapid, and Proton Vigilio EB1000. This system we have available here and in India, and most can RAM and esophageal Doppler. So transpulmonary thermodilation technique, we inject in transpulmonary thermodilation technique, we inject some saline inside the superior cava, and we measure the temperature difference in the femoral artery. So this is a pulmonary curve. This is pulmonary thermodilation technique, but this curve is the transpulmonary thermodilation technique, the PICO. And again, the cardiac output is again calculated by this square Hamilton principle. So here saline bolus of less than 8 degrees centigrade or at room temperature less than 24 degrees centigrade inject to central catheter and measure at the femoral or auricular artery. So again, we can here have a single measurement. The single measurement is used to calibrate the device every 8 hours and in period of hemodynamic instability. And continuous measurement, again, this device can give a single measurement and a continuous measurement also. So continuous measurement is usually by the analysis of the waveform of the arterial wave. So apart from this PICO system, apart from cardiac outputs that give lots of other parameters also in volume view, and that give lots of other parameters. So intrathoracic thermal volume, this is the product of cardiac output. We knew that already, cardiac output how we measure, and intrathoracic thermal volume is the cardiac output multiplied by the mean transit time. If you multiply the mean transit time, we get the intrathoracic thermal volume. Similarly, this is the total is the intrathoracic thermal volume. Similarly, the pulmonary thermal volume. This is the pulmonary thermal volume. That is the volume that is present inside the artery and inside the vascular system, and also outside the vascular system, but inside the lungs. So this is again we can directly calculate by cardiac output by descending transit time. So if we multiply, we will get the pulmonary thermal volume. So if we'll subtract this pulmonary thermal volume from the transthoracic thermal volume, then we'll get. So here, if we'll subtract the pulmonary thermal volume from the intrathoracic thermal volume, we get the global end diastolic volume. So if we subtract this one from whole this one, we get the global end diastolic volume. That is your volume inside the both RA, RB, and LA, LB. If we multiply this volume that are present inside the heart by 1.25 global end diastolic volume multiplied by 1.25, then we get the intrathoracic blood volume. Intrathoracic blood volume means the blood volume that is present inside the heart, RA, RB, LA, LB, and inside the pulmonary vascular bed. But that does not include the fluid that present outside the blood vessels. So if we'll subtract this intrathoracic blood volume from the total intrathoracic thermal volume, we'll get the extravascular lung water. So your extravascular lung water is the intrathoracic blood volume minus intrathoracic blood volume. It is pretty confusing. If you go through, that will be easy. So how it is important? So if we'll the ratio of extravascular lung water by pulmonary blood volume, that is known as your pulmonary vascular permeability index. So if your both extravascular lung water increases, also your pulmonary blood volume increases, your pulmonary vascular permeability here remain constant. Or in suppose this is a circumstance when you have cardiogenic pulmonary edema, when your pulmonary bed is again is filled with blood, again your so also your extravascular bed is also free. So but your pulmonary pulmonary vascular permeability index or capillary permeability index remains normal. But in case of suppose if a patient having ARDS, here your pulmonary vascular permeability index increases. So here your pulmonary blood volume remains same, but your extravascular lung water increases because your due to increase your permeability in the capillary. So here your pulmonary blood volume remain normal, but your extravascular lung water increases. So this is a PICO system that gives lots of parameters in volume view, also lots of parameters in from the pulse counter analysis. These are lots of, you can go through. I'm not going in detail because of time. So this is the PICO system. Then next is the transpulmonary indication dilation technique or electron dilation technique. So here again we can measure by single cardiac output measurement. We can also do continuous cardiac output measurement. Single cardiac output measured by lithium, can inject lithium chloride 2 ml or 0.3 millimole through a septum catheter, and concentration again measured downstream using a lithium selected electrode in the pulmonary artery. In the femoral artery or axillary artery. So cardiac output again a measured from the area under the curve. Again, single measurement we can do, and single measurement is used to calibrate the device every 8 hours and in period of hemodynamic instability. And continuous cardiac we can measure, and this is derived by analysis of pressure from analysis. So this is we can inject in the central vein, and we measure in the artery. But this technique is contraindicated in patient in treatment with lithium or non-depolarized muscle relaxant or in intracardiac disorder. So these are the previous PICO and LITCO. These are the semi-invasive technique. Another semi-invasive technique is the pressure weapon analysis. So there are three devices. The PICO system already discussed. This is to analyze arterial pulse here and analyze the area under the systolic portion of the curve to calculate the cardiac output. Again, LITCO system again this do the pulse per analysis to calculate the cardiac output. Again, another is the flow tracker visual technique. Here, the system calculate analyze the pulse wave in around 100 data points in 1 second and calculate over 20 seconds. So around that calculated about 2000 data points in 20 seconds and analyze the cardiac output from that 20-second duration. So advantage is the less invasive, but the disadvantage is that this reliable arterial test should be there, and the patient should not be having arrhythmia, intra-aortic balloon pump, or body temperature variation should not be there, extracorporeal filtration should not be there, or intracardiac sound should not be there. So this is again one of the PICO system, the pro acuity pulse fix. Perhaps uses the pulse wave, and this is the area under the systolic portion of the curve. And from this algorithm, this calculates the cardiac output. Here the percentage of error is about 41%. If the percent of error is about 25% or less than 25%, then the cardiac output measurement is acceptable. So this is study impact of the system vascular resistance on the accuracy of the pulse device. This pulse device does not accurately estimate the cardiac index. This study is conclusion, and another study similarly concludes that pulse did not reliably estimate the absolute value of the cardiac index. For tracking of fluid induced changes in cardiac index, the pulse is reliable. For fluid response, that is this is reliable. Again, flow track or Miscellaneous system, the EP1000. Again, I've already told about this. The percent of error is 13 to 75%, and fourth generation is the most more developed one, and is comparable to the thermodynamic technique. The thermodynamic technique or pulmonary thermodynamic technique that we measure by pulmonary catheter is the gold standard method, and we compare this different devices with that technique. So this study concluded that the trending ability of the fourth generation ProTrack or visual system greatly improved, but however the cardiac output measurement not clinically acceptable for clinical application. Again, another study again, degree of accuracy of the fourth generation ProTrack in patient with low cardiac index was not acceptable. Tracking ability remain the acceptable limit. So another is the PRAM pulse. Another is the PRAM system. Calculated cardiac output by measuring the area under the systolic portion of the curve, and systolic this curve volume is calculated by area under the systolic portion of the curve, and the Z. Z is the your point of instability, point of maximum instability, and the percent of error is 27%. And this study again concluded that the most care could be interchangeably used with a Doppler echo or a cardiac output estimation. and percentage of error here is about 41%. And transesophageal echocardiography, here we usually put a probe inside the esophagus, distal end of the esophagus, and we measure the cardiac output. So here cardiac output is how measured. This is basically cardiac output here cardiac output is the stroke volume into heart rate. So you have to calculate the stroke volume here. Stroke volume is nothing but about the volume of the cylinder. So stroke volume of cylinder means this is the area of the cylinder and the distance or the length of the cylinder. So area we can calculate by pi r square area and the distance by velocity time integral. So stroke volume is calculated by your area into distance. Pi r square radius we can calculate by the we can calculate from the normogram, or we can calculate from the Doppler echocardiography, and velocity time integral we can measure through the Doppler echocardiography. These are the when after load increases, the again amplitude decreases. Different graphs of the echocardiography. So when afterload increases, the amplitude decreases. When afterload decreases, your amplitude here increases. This is the normal graph. And this time, when there is ventricular failure, there is improper ejection. So you will have a sinus pattern. In hypovolemia, again you will have a tall and a narrow waves. So, what are the advantages? Advantage the easy placement and a minimal training needed. And these are the provide real continuous and real-time monitoring and low incidence of any hydrogen complication and minimal infectious risk. Disadvantage: this is the high cost, poor tolerance for our patient, and pro-displaced chances are there. And interobserved validity are also there. And here the issue of the error is 42%. So there's some with the semi-invasive technique, non-invasive technique, these are the again pulse control analysis and other the transferasic Doppler, bioelectrons impedance, and the partial carbon dioxide breathing method. So first the volume clump method is based on the physiological volume clump method based on the physiological three element intercell model. So here a cough is present around the middle phalanx or on the phalanx, and this cough inflate and deflate, and this is the finger, and the cough is inflated around the finger. So infrared light is emitted here, and another photodiode that senses the light. So during inflation and deflation, this infrared light again senses the blood flow inside the artery. So accordingly, they represents a waveform, and from this waveform, from the area under the from the systolic portion of the curve, the cardiac output is calculated. So cardiac output is factored into area under the systolic portion of the curve. So this is the 2007 model, and recently one is the EP 1000 model in 2014 that came by Edward Lifescience. So accuracy here, the percent of error is the 29 to 50%. So this study again concluded that finger cuff method provides a reasonable estimate of cardiac output and blood pressure monitoring. So another is the synapse system. Here have blood flow again detected by the infrared sensor. So here the pressure is exerted on the artery till the blood flow remain constant. So initially the cough inflates until your that presses the artery, and the blood flow remains a constant. There is a constant blood flow, and this is again this constant blood flow again analyzed and by one verify algorithm that to reproduce the cardiac output in non-invasive technique. So again percentage of error here is 25%, and this is again acceptable. Another is Applascar tonometry. Here, a pressure transducer placed between the pressure transducer placed over the radial artery against the your distal length radius, and the pressure changes is recorded by the transducer and arterial waveform is reproduced to calculate the area under the waveform, systolic portion of the curve, and subsequently measure the cardiac output. Again, percentage of error is 34%. And the pulse wave transit time. Pulse wave transit time means the time. What is transit time? Pulse wave transit time means the starting of the R wave and to the beginning of the next pulse wave or rise pulse wave rise point. So this is the R wave and subsequent rise pulse rise wave to this one. So this is the pulse wave transit time. So pulse wave transit time is inversely proportional to the stroke volume. Higher the stroke volume, raise with the pulse wave transit time. So from this different algorithm, this again cardiac output is calculated. Again, percentage of error is very high, 60%. Is the by transparency cardiography that we can do here at bedside. Here we can measure by again by by fundamental of volume of a cylinder. Here we can calculate by apical sorry the echocardiography long axis long axis view. We measure the diameter of the aorta. Subsequently in apical 5-chamber view we measure the velocity time integral. So stroke volume is the area from the diameter that we calculated here. We can get the LV outflow tract or area. So from diameter we pi r square we calculate the area. So from area we will multiply the velocity time integral in apical 5-chamber view. We get the stroke volume. I'm not going to the advantage disadvantage to know about all this. Again, the electric bioimpedance bioreactance. So here there are some electrodes that are transmit the electric current, and there are some other outer electrodes that receive the electric current. So changes in amplitude of the electric current when with respect to the changes in cardiac output is measured here. So from that this system calculates the cardiac output. So whether there is change in amplitude of the change, when there is change in amplitude, this is interpreted as a bioimpedance. When there is changes in the there is a phase shift. When there this was suppose initially your current phase with change in cardiac output, your phase again changes. So any change in phase here is again noted, and this system is known as the bioreactance. So bioreactance, you recognize your phase shift changes, but your bioimpedance you have notices your change in amplitude. So from this you calculate the cardiac output. So again percentage of error is about 42%. Again, carbon dioxide rebuilding method. This is again by based on fixed principle that you use this equation to calculate the cardiac output. This is a complex algorithm, but this system is again require a very ideal situation, and in critical patient it's not possible. So patient should be hemodynamically stable, minimally abnormality of gas exchange, minimal respects to be there, but all these ideal conditions are not possible in critical ill patient. So this algorithm is a purpose only. So percentage error here is about 24%. So this is about the cardiac output monitoring. Just briefly going about the capnography. So Kaplan graph is the graphical representation of the carbon dioxide level, and capnometer is the numerical value of the carbon dioxide level. So different methods that we measure the carbon dioxide level. That is the infrared spectrography. That's the most common one. Other is the molecular correlation spectrography, Raman spectrography, mass spectrography, and photoacoustics spectrography. In infrared spectrography, it has a most popular one, and carbon dioxide here the selectively observe the specific wavelength of the infrared. So since the amount of the light is absorbed is proportional to the concentration of absorbing molecule, that is the carbon dioxide, the concentration of the gas can be determined by comparing the measured absorbance with the absorbance of the known standard. So there are two type of capnograph, again mainstream capnograph, again and another is side stream capnograph. Mainstream capnograph, where the device is inserted on your endotracheal tube and behind your TPs. So in between your tube and your TPs, the device is installed here. Side stream capnograph, here your tube remains between the circuit and the endotracheal tube, and a sampling tube connected to the main sensor device. And carbon dioxide that went through this sampling tube and sensed by this capnograph. So it was shortage of time. I'm not going about this side stream. What are the advantages and disadvantages? We can close to these slides. So what are the components of a time capnograph? So there are two types of capnograph, volume capnograph, time capnograph. So carbon dioxide with time, and that's the most common and used. So there are different phases. The phase one is the baseline when there is ejection of your dead space ventilation or dead space air. So A represents the beginning of the expiration, and that start at zero. And there is when we exhale, there is initially the dead space air come out that does not contain any carbon dioxide or very minimal amount of carbon dioxide to detect. And phase B, this is the transition part of the curve. This is the phase B. This is a transition part of the curve from and represents the mixing of the dead space and alveolar gas. So this represents the dead space gas, minimum amount of dead space gas, and the more amount of the alveolar gas subsequently. So your carbon dioxide in exhaled gas again rises. So your curve again rises. The part C represents the alpha angle. This is the alpha angle and it represents the change to the alveolar gas. So here these are the dead space gas and alveolar gas. This is the alveolar gas, purely alveolar gas. So this is the alpha angle, and this represents from your mixed dead space and alveolar gas to the change to the alveolar gas. And this is the your expiratory, so the inspiratory phase, and this is the beta angle. The beta angle E is the end-tidal carbon dioxide here. End-tidal carbon dioxide, the numerical value we measure in the capnometer, and F is the beta angle. Beta angle that represents the change to the inspiratory part. This is F is the beta angle that represents the change to the inspiratory part. During inspiration, again fresh gas flow inside, so that contains very minimal amount of carbon dioxide. So again, this graph drops quickly. So when analyzing a capnograph, 4 to 5 points should be remembered. What is the frequency, what is the rhythm, height, and baseline and shape of the capnograph. So these are some of the capnograph waves. The dual wave capnograph is basically noticed in differential lung emptying, differential lung emptying. Like in patient with a transplanted lung, one healthy lung emptied subsequently, one diseased lung emptied in between. So that this gives a dual wave capnograph, or otherwise in a patient with endotracheal intubation. So ripple effect. This capnograph is recorded during a low frequency control ventilation. Again, slanting or slanting of the during the expiratory phase, slanting and prolongation of expiratory obstruction indicate of obstruction of your glass flow. This is because of your obstruction to airway, like in patient with COPD or a patient having bronchospasm. Again, same patient having bronchospasm COPD, your expiratory phase is having a gradual upflow. Here, event that causes an exponential decrease in the entire carbon dioxide. This is here you see the carbon dioxide again decreases suddenly. So this is maybe because of sudden hypertension of patient having a cardiac arrest or patient having a pulmonary embolism, and there is a transient decrease in EtCO2, which may for a small air embolus. Again, this is trend capnograph during cardiac arrest or during resuscitation. When rebreathing, in rebreathing, your baseline air gradually rises, and so also your high value of your carbon dioxide again rises. This is the cure cleft when patient started even you keep muscle relaxant in ICU patient when patient have subsequently with time have its own effect. This patient can have an inspiratory inspiratory effect during your expiratory phase. So this give rise to the cure cleft. In hypothermia, the value there is a decrease in value of the ETCO2, or in patient having a reduced metabolism, hypothermia or hyperventilation or small tidal volume ventilation, you can have a low value of ETCO2. Endometrial intubation, I already discussed that it will have to capnograph. And esophageal intubation, we'll see this type of ETCO2. Malignant hyperparesia, again you have a high ETCO2 value. During spontaneous ventilation, this type of we get. Hypoventilation gradually rising the ETCO2 value, and hyperventilation gradually decreasing the ETCO2 value. And a rebreathing baseline again increases gradually. So also ETCO2 value. So this is all about the ETCO2. Thank you.
Thank you, sir. Next, I would like to welcome Dr. Satyajit Chowdhury, sir, to please take the class on blood gas analysis and biostatistics. Over to you, sir.
Is it visible, Charan?
Yes, sir. Visible.
So, good evening, everyone. We are going to discuss something about APG, then we'll be discussing about biostatistics. So, patients will be trying to simplify as much as possible. What is the purpose of blood gas analysis? Purpose is mainly to know about the oxygenation, ventilation, and acid bed status of the patient. From the values of PO2 and SO2, we can know the oxygenation status. From the value of PCO2, we can know the ventilation status, and from pH, we can know the acid base status of the patient. And how does it help? It helps in managing the patient better, and also it guides the course of derangement and efficacy of the treatment. So, what are the informations we get in ABG? The two types of parameters we get, one is measured and other is calculated. Measured parameters are pH, PO2, partial pressure of oxygen, and partial pressure of carbon dioxide. And the calculated values are bicarbonate, saturation, base excess or base deficit of the patient. Now, there are certain conditions which lead to invalidation or modification of the ABG results. Delayed analysis, it causes consumption of oxygen and production of CO2. So PO2 value shows falsely low and PCO2 value becomes falsely high. So while taking a sample, better to keep in ice if we are planning to measure at a later period of time or we are transporting, because ice sample, it can maintain the values per 1 to 2 hours, but on ice sample, they become quickly invalid. Fever or hypothermia. Severe hypothermia or severe hypothermia can grossly affect the pH and PCO2 value. So for every decrease in temperature from 37 degrees centigrade, there occurs a drop in partial pressure of oxygen by 5 millimeter of mercury, and partial pressure of carbon dioxide drops by 2 millimeter of mercury, and pH increases. Similarly, heparin also causes changes in pH value. As it is an acid, the pH is normal or in alkaline range in the beginning, then heparin can lead to acidemia because of acidic heparin. And if the pH in the beginning is acidic, then because of heparin, the acidemia decreases because the mildly acidic heparin reduces the greater acidity of the blood. Similarly, uses of syringes, they affect the oxygenation value, but pH and PCO2 values remain unaffected. Leukocytosis and thrombocytosis, they cause consumption of increased oxygen, leading to falsely low PO2 value. Regulation of arterial pH is done by mainly buffers present in the body. Here, mainly the respiratory system and renal system come into play. The respiratory system role is by elimination of volatile acid like carbon dioxide, and kidney does its roles by retaining or regenerating bicarbonate. Bicarbonate actually two types of value we get. One is standard bicarbonate value, another is actual. Standard is measured in lab after equilibration of blood PCO2 to 40 millimeter mercury. The normal value is 22 to 26. Mean we take is 24. And actual bicarbonate value is calculated from pH and PCO2. In a normal patient, both the values should be equal. Now coming to interpretation, we use these three approaches. So we'll be discussing, but we're not going in detail about all these three approaches because it will take a lot of time. What are the normal components of ABG report? pH, normal value, we all know about these things. pH, PCO2, PO2, bicarbonate, and saturation of oxygen. These are the normal range. Now, the relationship between pH and bicarbonate, pH and H plus ion at physiologic pH. H plus ion is calculated from carbon dioxide and bicarbonate with this formula 24 into CO2 divided by bicarbonate concentration. And the range of PCM variation is very small. So pH is inversely related to H plus ion. A change in pH of 1 represents a 10-fold change in hydrogen ion value. This is a table showing corresponding value of H plus with the value of pH. As you can see, as the pH increases, or reverse, we can see as the H plus ion concentration increases, the pH value gradually decreases. What is the step one? Step one is to assess the validity of the result, whether the ABG shown is correct or not. This can be assessed by knowing the Anderson-Hasselbalch equation. Here the hydrogen ion value is calculated initially by using PCO2 and bicarbonate level. And if there is discrepancy between the two results, as shown in the previous chart, the blood should be reanalyzed. And bicarbonate should be within 1 to 3 milliequivalent of the total carbon dioxide level. So the difference of more than 4 milliequivalent per liter means there is some technical error. Which is the primary disturbance. Next, we should know what is the main issue, whether it is respiratory or metabolic. If the pH is in decreasing less than 7.4, we call it acidosis, and it's more than 7.4, we call it alkalosis. Respiratory acidosis, mainly the changes because of partial pressure of carbon dioxide. There is increased retention of carbon dioxide in the blood, leading to increase in PCO2 value of more than 40, causing respiratory acidosis. Similarly, PCO2 value is less than 40, we call it respiratory alkalosis. The primary problem is in the lungs. Similarly, for metabolic acidosis diagnosis, the bicarbonate value should be less than 24, and if its value is more than 24, we call it metabolic alkalosis. It's a broad classification of metabolic and respiratory disease. Now, next step is to know what is acidosis and alkalosis we knew. Then we should know what is acidosis, a process that would cause acidemia if not compensated is called acidosis. And acidemia is when the pH is less than 7.3. Similarly, alkalemia is pH greater than 7.45, and the process is called alkalosis. So there are mainly four broad primary acid-base disorders: metabolic acidosis, alkalosis, and respiratory acidosis and alkalosis. Now the step 3 is identifying the primary disorder. For that, we need to know the changes in PCO2 and bicarbonate values. If the PCO2 is deranged in the same direction as pH, then the primary disorder is metabolic. As you can see, and if the PCO2 is changing in the opposite direction of pH, then the primary disorder is respiratory. Here in the example, the PCO2 is increased from 40 to 60 and bicarb pH value has decreased from 7.4 to 7.25. That means the PCO2 and pH are moving in the opposite direction. So the primary disorder is supposed to be respiratory, and the PCO2 is high and acidosis, the pH is acidic, then we call it respiratory acidosis. Next step is know about compensation. It is a secondary adaptive response to mitigate the changes in atrial pH, so acid-base homeostasis is maintained. Compensation doesn't return the pH to complete normal, and it is never overcompensated. So respiratory compensation occurs in an hour, but renal compensation takes longer time, sometimes 2 to 5 days also. If a given patient is not compensating as predicted, then second or third acid-base disorder must be present. Now, what are the rules of compensation? First, for metabolic acidosis, the 1.5 plus 8 rule, that means we know the bicarbonate value. Usually primary disorder is metabolic acidosis. So the expected PCO2 is calculated from the bicarbonate value by 1.5 times the bicarbonate plus 8. Accordingly, by seeing the result, we will decide whether it is been compensated or not. Similarly, for metabolic alkalosis, PCO2 is calculated by multiplying bicarbonate with 0.7 plus 20. And for acute respiratory acidosis, the rule is 1 for 10 rule. That is expected bicarbonate is 24 into actual PCO2 minus 40 divided by 10. And for chronic respiratory acidosis, this is 24 plus 4 into actual PCO2 minus 40 divided by 10. So, and then acute respiratory alkalosis and chronic respiratory alkalosis, we can remember 2 for 10 rule and 5 for 10 rule. This is the formula for knowing expected bicarbonate value. Now, if the compensation as per calculation from the compensation, we can know whether it is a single acid-base disorder or multiple acid-base disorder. And there is multiple case scenarios arising, we call it a mixed disorder. Now, the next step is calculating the anion gap. Calculation of the anion gap is useful in the initial evaluation of the metabolic acidosis. An elevated anion gap usually indicates the production of pathologic acid. Those are the unmeasured anion. And the total serum cations must be total serum anions in a normal patient, normal case scenario. And when it is different, we have to calculate the anion gap. And it is calculated by broadly sodium concentration minus chloride plus bicarbonate concentration. A normal value is 10 to 12. Albumin is the major unmeasured anion, and it should be corrected if there are gross changes in serum albumin level. This is the corrected anion gap formula. It's anion gap plus 4 minus albumin into 2.5. Now, what is normal anion gap metabolic acidosis? It occurs when the decrease in bicarbonate corresponds with an increase in chloride ion to retain electron neutrality. That is also called hyperchloremic metabolic acidosis. It leads to increased renal excretion of ammonium ion. And measurement of urinary ammonium can be used to differentiate between renal and extrarenal causes. Urinary anion gap and urinary osmolar gap are often used as surrogate measures for urinary ammonium level. And knowing the ABC or using the anion gap approach, if the anion gap is more than 12, it's anion gap acidosis, there occurs accumulation of unmeasured anions. And if there is anion gap is less than 12, that is called non-anion gap acidosis, there occurs more loss of bicarbonate. So acidosis is due to loss of bicarbonate, also called hyperchloremic acidosis. This is the formula of anion gap calculation, and the bicarbonate value plus anion gap minus 12 should be 24. If the value is more than 24, there is additional component of metabolic alkalosis, and if value is less than 24, there is hidden non-anion gap metabolic acidosis is present. Now, what is delta ratio? It is the change in anion gap divided by change in bicarbonate value. If delta ratio, can know this table. If the delta ratio is less than 0.4, that is called normal anion gap acidosis or magma. It's between 0.4 to 1. It is called magma plus magma high anion gap plus normal anion gap acidosis. The values between 1 to 2, that means there is pure high anion gap metabolic acidosis, and if there is more than 2, there is some component of metabolic alkalosis along with high anion gap acidosis. Also from ABG, we can know the adipasive oxygenation status of the patient. These are the normal value of PO2 and SO2. If value is less than 80, we call it hypoxemia PO2. These are the causes of hypoxia. Now, analyzing the adequacy of oxygen by using the alveolar atrial gradient, oxygen gradient. If the PO2 is always calculated based on FR2, PCO2, and barometric pressure. So this is the formula we use to calculate partial pressure of oxygen in the alveolar blood. That is FR2 into atmospheric pressure or barometric pressure minus 47 minus PCO2 divided by respiratory quotient, with is normal alveolar atrial gradient increases. So if A gradient is normal, means in a hypoxic patient, the gradient is normal, means there is hypoventilation. And if the gradient is elevated, that means there is some ventilation perfusion mismatch or something is present, and there occurs impaired diffusion. And NPF ratio index is used to know about the severity of ARDS or classification of ARDS, that we know. Saturation gap is the difference in saturation of oxygen minus saturation of oxygen in the actual blood is more than 5% is significant, causes methemoglobinemia and carboxyhemoglobinemia. Now, let's discuss about the examples. You can write the answers in the chat box, or you can unmute yourself and tell the answers. This is a patient coming to an emergency who is a 55-year-old obese male, and he complains of daytime somnolence, and he has the following ABG. Maintaining saturation room air, pH 7.33, PCO2 64 elevated, PO2 is less 40, bicarbonate is elevated 33.3, base excess 5.4. So what is the acid-base status of the patient, and what is the gradient, and what is the likely diagnosis? So anybody can say, or you can type in the chat box also.
Looks chronic respiratory acidosis as patient has complained of daytime somnolence.
So what is the likely diagnosis?
COPD. COPD.
Yeah, COPD. And also maybe OSA. Patient may have obstructive sleep apnea component. And A gradient we can calculate, it will be coming around 33. That is more than the normal range. So from that, what we can interfere? That hypoxia is not purely due to hypoventilation. There might be some shunting may be present because gradient is very high. It is coming around 33. This is a case surgical resident called to see a 73-year-old woman with COPD, diagnosed COPD. He's called to work off for elective cholecystectomy. And doing an ABG, the finding is pH 7.55, that is alkalosis means PO2 63, PCO2 is 56, and bicarbonate is 48.3. So why is the hypercapnic? Why the PCO2 is high? Anybody? The bicarbonate is high and pH is high. So primary there will be metabolic alkalosis, severe primary metabolic alkalosis with some respiratory compensation. And the A gradient calculated is coming around 20. And third question, 3 measures that can improve this kind of acid-base disturbance.
Metabolic alkalosis may be due to chronic vomiting, as patient had history of cholecystitis and admitted for cholecystectomy. Then diuretic use and any fistulas.
Okay, good. So what are the measures we can take? One is you can say the diuretic use. If he is using diuretic, then sees the use of diuretics. And
Hypokalemia related
Yeah.
also metabolic alkalosis.
exactly. Hypokalemia can be corrected. And third option, we can use acetazolamide also, because the bicarbonate level is very high. Next, you're asked to review a 15-year-old male who has been receiving treatment for asthma in ED for 3 hours. The concern is persistent hypocapnia. The patient is now tachypneic with mild generalized wheeze. This is the ABG finding, pH 7.5, and after 3 hours, the pH becomes 7.39. PO2 from 82 becomes 175. PCO2 is same. Bicarbonate is compensating 17.9. This is the sodium and chloride value. So interpret the AA gradient value. Describe the acid-base status and how the asthma improved. You can give reasons. The explanation for unchanged PCO2 values. So it will take time. Gradient becomes from 239 initially at 7 m. It becomes 150 at 10 m. So indicating improvement because there is lessening in the mismatch or shunting. And the second question, the acid-base status. First, at 7 m, what is the status? PCO2 is 30 and pH is 7.5. So acute respiratory alkalosis. And at 10 a.m. Changes to dual. Since PCO2 is normal, pH is 7.39 and bicarbonate is 17.9. So because of compensation, there is mixed picture is coming along with respiratory alkalosis. There is also metabolic acidosis with increase in anion gap value. And status has improved definitely because of there is increasing PO2 value. Likely cause of unchanged PCO2. Salbutamol induced because the patient must have been given nebulization with salbutamol. So that might have led to lactic acidosis superimposed and improving bronchospasm. So that may be a reason. If bronchospasm is improving and PCO2 remains normal. A 20-year-old woman involved in a motor vehicle accident, 32 weeks pregnant, and has a rib fracture. For which she has received analgesic. Now the patient is in shock and the abdomen is non-tender. ABG is showing pH 7.3 with FiO2 of 0.5, PO2 150, PCO2 42, bicarbonate 21.3. Describe the acid-base status.
It's respiratory acidosis, as in third trimester, that should be PCO2 less.
Very good. And the gradient, A gradient is coming to be 158. So that means there is some shunting or VQ mismatch. And that is also explained because patient has got some chest wall injury and already the patient is pregnant. So FRC was already low. Along with that, this chest wall injury leading to hypoventilation. So there is cross ventilation perfusion mismatch. 45-year-old alcoholic treated with flucloxacillin for multiple staphylococcal lung abscess. Patient is improving despite continuing pyrexia and muscle aches requiring regular paracetamol use. After 3 weeks, the patient again becomes hospitalized and the EBG findings showing pH severe acidosis 7.2, PCO2 24, bicarbonate 9.5, base excess minus 18.4. These are the electrolytes value. Creatinine is normal, lactate normal. So what is the general description of the acid base status of the patient and what is the likely diagnosis? Severe metabolic acidosis is present.
Anion gap metabolic acidosis.
Yeah, what is the anion gap? 135 minus
25.
yeah 25. So high anion gap metabolic acidosis. Predisposing factor. What can be the predisposing factor from the given scenario?
PCM.
Yeah, PCM and flucloxacillin in sepsis, so leading to high anion gap metabolic acidosis. And how the diagnosis can be confirmed? We can go for a urine analysis for the acids, organic acids. Good answer. Now, 18-year-old woman suffering from acute renal failure owing to rhabdomyolysis post heroin overdose. She is hemodynamically stable and is undergoing continuous hemodiafiltration with standard dialysis and replacement fluid for 8 days. This is the ABG. pH 7.45, PCO2 45, Pica 31, base excess 5.5, electrolytes, potassium slightly lower side, chloride is lower side, lactate is elevated, it's 5. So anion gap is given already 10. Describe the acid base status. And why is the anion gap not elevated in presence of hyperlactatemia?
Metabolic alkalosis.
Metabolic alkalosis, but the more complete answer will be compensated metabolic alkalosis with hyperlactatemia. And anion gap not elevated in presence of hyperlactatemia. Why? See the albumin value, that is cross hypoalbuminemia. So the anion gap is not elevated. And also, what is the explanation?
Hypokalemia and hypochloremia induced to metabolic alkalosis.
The patient is undergoing dialysis. So the lactate level which elevated is incompletely converted because the patient is undergoing dialysis.
Citrate.
In this case, the lactate that has been metabolized and is replaced by bicarbonate, so leading to metabolic alkalosis. Next question, 30-year-old presenting with fever, vomiting, sweatiness, confusion, and agitation. This is the ABG value, pH 7.4, PCO2 25, PO2 105, Bica 15.3, sodium chloride is a normal range. So describe the acid base status and two possible diagnoses. Fever, vomiting, confusion, agitation. Mhm. Not audible. What is the anion gap? pH is normal and the anion gap is elevated. So there is a mixed pattern, respiratory alkalosis and metabolic acidosis with high anion gap. And two possible diagnoses, what can be?
Alcoholic.
Alcoholic, fulminant hepatic failure, aspirin poisoning also can lead to this type of medicines. The last one, 60-year-old woman presenting with pneumonia, shock, and respiratory distress. The ABG is showing pH of 7.15, severe acidosis, PCO2 30, bicarbonate 10, severe metabolic acidosis. Base 6 is minus 18.5. So describe the acid-base status. 60-year pneumonia, shock.
Metabolic acidosis with respiratory alkalosis. Respiratory acidosis. Mixed acidosis.
Yeah, mixed acidosis. And what is the A gradient? Okay, till the time it is coming around 200. So there is something or BK mismatch is present. The patient will require intubation or not with this ABC value. Obviously, the patient is already
Intubation is necessary as there is respiratory acidosis is there, and patient may get fatigue if we do not intubate here.
Okay. Good. So I'll be discussing this much of example. Next, we'll be discussing about some biostatistics. Is visible? So what is sensitivity versus specificity? Reliable screening test can improve health, but inappropriate screening harms healthy individuals and squander resources. So we must know about the sensitivity and specificity of a particular test we are undertaking for diagnosis of a particular disease. And validity of a test means to what extent a screening test accurately measures what it intends to measure. So when that test result comes to be positive and the disease actually present, that we call true positive. And if the disease is absent but the test result comes to be positive, it is called false positive. Similar, false negative, when the test result is negative but the disease is present, that is called false negative. And disease is absent and test result is negative, that is called true negative. So sensitivity means true positive divided by true positive plus C means false negative. So all the disease patient, true positive divided by true positive plus false negative is determines sensitivity of the test. And for specificity is determined by true negative divided by false positive plus true negative. That determines the specificity of a test. Now, there are various study designs broadly classified into observational study and interventional study. Observational study include case report, case series, case control study, and cohort studies. And interventional studies include RCTs and non-randomized studies or non-RCTs. First, coming to case control study, it is a observational or analytical study. Generally, these are retrospective study, means backward going study. Once we know the effect, then we are going to the cause of the effect. So begins with the effect or disease condition, and the investigator goes back in time to try and identify any factor associated with the condition. A similar group of patients with masked characteristic apart from the disease is taken as the control. That is called control group, and it should be closely masked with the case group. So after the exposure is present, disease present, the study begins here. And then we go back in time to know about the cause of the disease. So here you can see after the exposure, whether the patient develops disease present or not. If the exposure is present and the patient develops the disease, that means that we take it A, and there is no exposure, still the disease is present, that we call C. And the exposure is present, but in control group, the disease is absent, that is called B, and is exposure is absent and the disease is absent, that is taken as D. What is odds ratio? That is AD divided by BC, and what is relative risk? If the incidence of disease among exposed, that means A divided by A plus B, and divided by incidence of disease among non-exposed, that is C divided by C plus D. So what is the advantage of case control study? It's simple, easy, and less expensive, less time consuming, useful in disease with long latent period, and no dropout of cases or attrition, because we're not taking fresh cases, we're going back, so no loss to follow, and useful in research on rare diseases, and also not harming or doing any risk to the patient. So ethical issues are minimal. Disadvantage, there is various bias like recall bias, selection bias, observation bias. Temporality of association cannot be established, and natural history of disease cannot be established. Incidence of disease cannot be calculated. Relative risk, attributable risk cannot be calculated. Selection of appropriate control group may be difficult and cannot distinguish between main cause and other associated factors. Cannot evaluate prophylactic treatment of a disease. Next, coming to cohort study, is an observational or analytical study. Obtain evidence to support or refute existence of association between a cause and disease. Usually, these are prospective study or longitudinal study, or also called forward-looking study. Follow-up at different time points are done while actively looking for the outcome. And this is also called cause to effect study. Example, role of exposure to dyes in the development of bladder cancer. What is the advantage of cohort study? There is no bias. Temporarily or temporality of association cannot be established as the study follows. Natural history of disease can be studied. One exposure leading to multiple outcomes can be studied, and incidence can be calculated. Incidence is number of new cases, and the relative risk, attributable risk can be calculated. And disadvantage is more time consuming, more expensive, and requires more resources, usually involves larger number of people, and patient loss to follow-up can occur, and rare diseases cannot be studied. Now, what are the variants of cohort study? One is nested case control study, which is type of cohort study. Begins like a typical case control study, but then follows up the patients over a period of time. And what is retrospective or historic cohort study? It involves studying hospital records, hence possible only in situations where perfect patient records are maintained. Example, diethyl stalbestrol was identified as a causative agent for vaginal adenocarcinoma in young women whose mothers had received the drug during pregnancy. Similarly, high-dose oxygen is a cause of retrolental fibroplasia was found in premature infants with NICU admission. So these were diagnosed because of 4 studies. Next, coming to randomized control study, is a experimental based study design. It's a best study design. Crossover of patients can be done, which further increases the quality of the study. Target population should be identified before conducting the study, refers to the population on whom the result of the study will be generalized. The study should include a part of this target population itself. And here must be remembered that there is mandatory requirement of ethical committee approval and written informed consent in a language in which the patient can understand should be taken before the study is started. And blinding is necessary to carry out randomized controlled trial. What are the advantages? Causal inference can be made strongest evidence among all study designs. Randomization ensures removal of bias, minimization of effect of confounding factors, and the study can be tailored to answer any specific question. Disadvantage, it is expensive, not blinded. Then investigator bias may be present and loss to follow-up may occur. And if a new drug is being tested and seen to be toxic, the study may have to be discontinued. Here, there is a population and sample population is taken from which a volunteer group is targeted. Then randomization is done and allocation is made. Then actual assignment that can be followed by masking or blinding of subject as to their assigned group. Next is the prospective evaluation period is taken before reaching the outcomes. Then outcome is evaluated during which assessors can be masked as to the subjects assigned group. Now, what are the various types of randomization? First is simple randomization, like toss a coin, a random digit table, easy to implement, but unequal distribution of subjects may occur. Random permitted blocks to equalize the number of subjects on each treatment. Stratified permitted block randomization. Stratum is first defined, following which block randomization is performed with each stratum. Play the winner design, 2-1 bandit design, adaptive minimalization. These are the various types of randomization. Now, coming to hypothesis testing. What is null hypothesis? When we begin the study, we begin with the assumption that there is no significant difference between the two study groups. This is the null hypothesis. An alternate hypothesis begin the study with the assumption that there exists a difference between the two groups. So when the null hypothesis is true, means there is no difference, but based on study result, it is accepted, then that is called correct decision. But when the null hypothesis is true and the study result is rejects, then it means there is a difference that is called false positive error or type 1 error. Similarly, when the null hypothesis is false, means there is difference present, but the study is accepted. That is called false negative error or type 2 error. So what is the type 1 error and type 2 error difference? Type 1 error, when a study concludes that there is a difference between the analyzed groups, when in fact there is no difference. That is called false positive error or type 1 error. Here we have rejected a null hypothesis, which in reality is true. By convention, type 1 error is more dangerous than type 2 error because actually there is a difference, but actually there is no difference, but we have concluded that there is a difference in two groups, and maximum permissible in any study group is 5%. Therefore, confidence interval should be more than 95% in any study group. And what is type 2 error or beta error? When a study concludes that there is no difference between the two study groups, but in fact there is a difference, there is false negative error, is called type 2 error. We have accepted a null hypothesis, which in reality is false, and permissible type 2 error is 20%. Now, next, should know about some data analysis, mainly two tests: qualitative or non-numerical data analysis and quantitative. In qualitative, two types: nominal, ordinal; quantitative, discrete or continuous. Again, continuous can be interval or ratio. These are various statistical tests. We'll be discussing one by one. What is the difference between unpaired t-test and paired t-test? In unpaired t-test, two independent groups are compared. In paired t-test, sample group is compared, example, before and after intervention. So these are related, but in unpaired t-test, the groups are not related. And in unpaired t-test, intragroup variability is present. Here in paired, no variability is present in the intragroup. More sample size is required to increase the power of the study in an paired t-test, and in paired t-test, comparatively lesser sample size is required. What is ANOVA or analysis of variance? Extension of t-test, whereas t-test can compare only two means. ANOVA can compare more than two means across various groups. When there are more than two groups, a series of tests would be needed to compare them, which can add unto the exponential error or type 1 error. Hence, ANOVA is applied. It can be one-way or multi-factor. One-way ANOVA is used to compare the means of two or more levels of a single independent variable. And multi-factor ANOVA is used when there are two or more independent variables are present. Another version of ANOVA is MANOVA, that is multiple analysis of variance. It's used when two or more dependent variables that are generally related in some way are used for comparison. Then what is chi-square test? It compares categorical responses between two or more groups. It's used to examine difference between two groups consisting of categorical variables, example, gender and marital status. Here the data should be nominal or ordinal, as this is a test of proportion. So chi-square test summarizes discrepancy between observed and expected frequencies. Smaller the discrepancy between the observed and expected scores, smaller is the value of the result of chi-square test. And what is correlation? What is regression? Correlation, when a relationship between two quantitative variables on a scattered plot is present. Two variables can have no correlation. They may have positive or direct relationship or indirect or negative relationship. Positive, more the value of prostate-specific antigen, higher the chances of prostate cancer. That is a positive correlation. Similarly, negative, and the SDL value is more, then there is lesser chance of cardiovascular disease. That is negative correlation. So correlation coefficient gives the strength and direction of association. What is regression? First is linear regression is a quantitative data, is a method of estimating or predicting a value on some dependent variable, given the values of one or more independent variables. Like correlation, regression tells the association or relationship between variables. The primary purpose of regression is prediction. Example, health is predicted by body weight, medical history, disease status, or marital status of the patient. Again, two types of regression, simple and multiple. What is simple regression? It's an attempt to predict the dependent variable with the help of a single independent variable. Example, association between smoking and lung cancer. And what is multiple regression? When many independent variables are used to predict one dependent variable. Example, multiple factors to predict the health of the patient. Like lifestyle, like the triglyceride level, diabetic, hypertensive status, all this. What is logistic regression? It's a mix of quantitative and qualitative data to predict dichotomous variables, such as the presence or absence of a specific outcome based on a specific set of independent or predictor variables. What is Kaplan-Meier survival analysis? Kaplan-Meier estimate is one of the best options to be used to measure the fraction of subjects living for a certain amount of time after treatment. In clinical trials, the effect of an intervention is assessed by measuring the number of subjects survived or saved after that intervention over a period of time. The time starting from a defined point to the occurrence of a given event. For example, death is called as survival time and the analysis of group data as survival analysis. So the Kaplan-Meier estimate is the simplest way of computing the survival over time in spite of difficulties associated with subjects or situations like loss to follow-up or dropout. Thank you for your patient hearing. In doubt, you can share in the chat box. We'll try to answer.
Thank you, sir. Next, I would like to welcome Dr. Biswajit Naik, sir, to take the lecture on bedside 2D echo, lung ultrasonography, and FAST. Over to you, sir.
Am I audible, Tirian?
Yes, audible.
Okay. Good evening. So my topic is ultrasound in critical care. So I divided in 3 parts: the bedside 2D echo, long ultrasound, fast and e-fast. It's a little bit lengthy, but have patience. So first, discuss regarding the 2D echo. Coming to basics, image generation. The echography is a type of ultrasound test that uses the high-pitched sound waves to produce an image of the heart. These sound waves sent through a device called transducer and reflect from the various structures of the heart. These echo waves are converted into pictures that can be seen in the monitor. Here, from the transducer, the sound waves are emitted. It will hit to the tissue, and some are reflected and some waves are transmitted. The repeated waves then received at the transducer, and here the sound waves are converted into the electrical energy. So this is called the piezoelectric effect. Coming to components, one is the false generator, applies the high amplitude voltage to energize the crystals. Transducer converts the energy, and the receiver detects and amplifies the weak signals and display the ultrasound signals to the monitor. Indication: condition of the valvular structures and motions, ventricular muscle, septal muscle, and the muscle thickness to calculate the ejection fraction, pericardial sac, and AMI. And initial evaluation of the suspected infective endocarditis if the positive blood pressure there is new murmur, and evaluation of the cardiac mass like tumor or thrombus. Coming to position, the semi-recommended position on the left side with head elevated, left arm is stuck at the head and right arm on the right side of the body. There are 4 echo windows. This is suprasternal, this is left parasternal, it's apical, and 4th one is subcostal. Come to parasternal, there are 2 view: parasternal long axis and parasternal short axis. In the parasternal long axis view, called plaques view, the transducer position is in the left sternal edge, 2nd to 4th intercostal space, and the marker is points toward the right shoulder. So these are the structures we can found. Most echo studies are begin with this view. Here you can find LV, LVOT. Here is alveoli. There is septum, interventral septum, and this is LA, left rectum. Now coming to short axis view, just turning 90-degree clockwise from the plaques view, we can get the short axis view. Here we can get the left atrium, right atrium, RV outflow, and aortic valve. We can get actually 3 to 4 views by tilting the transducer on the axis between the left hip and right shoulder. So that you can get the view from the base like aortic level to the LV apex. Let's example at the papillary muscle level. Here we can see there is a LV. It is a lateral wall of the LV. It is the inferior wall. It is the intervertebral septum as there is RV. So, and here is the anterior wall. So this is the picture where we can see best describing the any LV wall motion abnormality and also know the LV wall thickness. So already discussed the papillary mid papillary level. Another is at the mitral valve level. This is a fish mouth view, and other is the at the base of the heart or aortic valve level, also called Mercedes-Benz view at the aortic valve. Now coming to apical four-chamber view, transducer at the apex of the heart. Here the dot is towards the left of the shoulder. Here you can get all the four-chamber RA-RB, LA-LB, and with the valves. And if we tilt the transducer to the slight anterior angulation to chest wall, then we can get the five-chamber view. As there is, you can find extra, that is a LVOT, left ventral outflow tract. In the apical four-chamber view, it is mainly used for to detect the diastolic dysfunction, valvular regurgitation, and also calculating the cardiac output. Coming to apical two-chamber view, but just turning to 45-degree anticlockwise from the apical four-chamber view, we can get the two-chamber view. This is a good picture to assess the LV anterior wall and LV inferior wall function. Coming to suprasternal view. Suprasternal view, the transducer is placed in the suprasternal notch and the marker point towards the left jaw. Here the subject lies supine with the neck hyperextended. The head is slightly towards the left. And here we can see the arc of aorta. This total arc of aorta can be easily seen. Coming to subcostal view, here transducer is in the gypsysternum, and the marker point towards the left shoulder. The subject lies supine with head slight low or with no pillow. Here we can get best images with the relaxed and during the inspiration. Here we can see in septum and interatrial septum can also seen, and it's the best view to see the pericardial effusion, and also descending abdominal aorta can be seen here. The superficial view with long axis, we can see the IVC. IVC can be seen here below the liver, and here is the hepatic vein, and it is drained to the right atrium. From IVC, we can know the IVC collapsibility. From spontaneously breathing patient, we tell the patient to take a deep breath, and IVC is maximum during the expiration phase and minimum during the inspiratory phase. Just reverse in the patient having ventilated patient. The maximum in the IVC diameter in the inspiration and minimum in the expiration phase. You can see how the IVC is collapsing with the respiration here. Here you can find there is small and so much collapse with the respiration. And here the IVC is totally dilated and non-collapsed. IVC, here you can, in the M mode, you can see there is so much description in the diameter with the respiration. And if we give the fluid and volume expansion, then there is the discrepancy is decreased here. So in the superficial view with the M mode, we can see with this is a ventilator graph. With the peak of the inspiration, the diameter is the maximum, IVC diameter is maximum, and at the expiratory phase, this is the minimum. So from this, we can calculate the distensibility index. That is the difference of these two divided by minimum diameter. This is the data. now coming to modalities. The conventional echo like 2D echo and M mode, and Doppler echo like continuous wave, pulse wave, and color flow. This is normal ejection fraction. You can see by eyeballing. Here you can see there is inward movement of the endomyocardial point towards the lumen. Here is a mild reduce of the ejection fraction as there is less movement of the endomyocardial border towards the lumen. It is moderate, reduced. And here you can find severely reduced ejection fraction, hardly the moving to the lumen of the this peptide muscle. In 2012, this journal showing measurement of the left ventricular ejection fraction by measuring mitral valve E point to septal separation called EPSS. What is EPSS? So in personal long axis view, in M mode, we measure the distance of the mitral valve, anterior lifted of the mitral valve to the septum, interventricular septum. This distance is the measuring factor. If the distance is less than 8, so it is considered normal EF. And if it is the distance is 8 to 18, it is moderate to mild to moderate to reduced. And if it's more than 18, then this is suggestive of severely reduced ejection fraction. And we can calculate the ejection fraction from this formula 70.5 minus 2.5 times of the EPSS length in millimeter. Now another method when from fractional shortening, that is the left ventricle. This is obtained from the similar same Black's view in the M mode. Then we can measure the left ventricle end diastolic diameter and left ventricle end systolic diameter. From this, we can measure the ejection fraction. So its fractional percent normal is 25 to 43, and in severely reduced, it is can up to less than 14. And something related to right ventricular function. So here we can measure TAPSET, tricuspid annular plane systolic excursion. Here we at the apical fourth chamber view, at the peak of the systole, we can measure. We can put the cursor to the lateral lift of the tricuspid valve, so that we can measure in the M mode. We can measure the what is the excursion, what is the distance here. That is called TAPSET. And if it's less than 16, then it is severe RV systolic dysfunction. The advantage is simple, less dependent on the optimal image quality, reproducible, doesn't require sophisticated equipment or prolonged image analysis. But disadvantage is the heart is a 3D structure, but how to judge with from that single displacement. Here, a view of a pericardial effusion. It's between the parietal and visceral pericardium. We can have the fluid, which is anechoic. But here we can see after to the more glistening parietal pericardium, there is the pleural effusion. Should not miss with the pericardial effusion. Here, in the apical fourth chamber view, we have some fluid here, so it's absence of RA. So in the if we put in the short axis view, we can definitely there is complete collapse of the RV. So this confirm the diagnosis of the cardiac tamponade in this case. Here the right ventricular clot, you can see inside the ventricle. Here the mitral regurgitation. In the systolic phase, there is some amount of blood is entering into the LA, having the mosaic pattern. It is called mitral leak. Coming to aortic regurgitation, here similarly, During the diastole phase, the blood from the aorta enter into the LV with mosaic pattern. It's called aortic regurgitation. So, summarizing, every intensivist should be competent to do the basic echo to answer the is LV is working or how it's working, to know the preload assessment. Is there a right hand problem? Is there any tamponade? On the LV working, eyeballing is most commonly used. Do not need to give a number to the EF, and good moderate pour is enough. M mode can also be used, and methods to quantify the EF by Simpson method. Eyeballing, you can see the normal. There is a reduced LV function. Here you can see the severely reduced LV function, barely contracting. On preload assessment, chamber, we have looked for the chamber size and contraction, IVC assessment, Doppler assessment, the mitral valve inflow at EY ratio. Here is the normal LV. Here is the hypodynamic. You can see the papillary muscle opposed to each other. It's called kissing sign. Here the IVC is complete collapse with respiration. Here it is dilated, so pretty non-responsive. Coming with pulse wave, we can know ultrasound signals are sent out in short burst of the pulses. Here the cursor should be in between the mitral valve, at the apex of the mitral valve. Then we get the picture as E and A on the M mode. So E by A is normally between 0.7 to 1.5. If it's less than 0.75, then it is mild diastole dysfunction, and if it's more than 1.5, then it is definitely severe diastole dysfunction. Here we can find the E by A ratio is 2.2. So here is severe diastole dysfunction. Here is the E and here is the A. Now coming to LVOT and calculation of the stroke volume. Similarly, pulse wave to the at the aortic level, we can measure the stroke volume by calculating the volume by from the area and the distance length. So first measuring the area on the aortic valve level, we can measure the distance, and from pi r square, we can in centimeter we can get the area, so LVOT area, and from the pulse wave at the aortic level, we can get the VTI. There we can calculate the volume. So in pulse wave Doppler, putting in the LVOT aortic level, we can calculate this VTI. Usually VTI normal is 18 to 25 centimeters, and here you can find 20. So here is normal. From that we can get the stroke volume, and from that we can get the cardiac output by multiplying heart rate. Now coming to is there any problem with the right heart? We can now from check the RA-RB dilation, TAPSE. Here we see normal LB, but here when the RB is dilated, it is compressed. The septum is towards right side, making the left ventricle to decept. You can find the decept LB. And also must look for that any tamponade. West will be with subcostal. Look for the diastolic collapse. Here you can see there is diastolic. In diastolic there is total collapse of the LV. So now coming to long ultrasound. Second part. So probe is curvilinear, as there is medium frequencies which are for abdominal contents and lungs also. So there is 3 zones are there according to blue protocol. The upper blue point, the lower blue point, and the flaps point. Anterior blue point, below to that is the anteromedial, is the lower blue point, and flaps point is the posteriorly. So if we put our 2 hands excluding the thumbs below the clavicle, we get the on the upper hand, it is middle of the upper hand, we get the anterior point. and in upper point, and if it is in the middle of the lower hand, we get the lower blueprint. And if we transect a horizontal line from that lower point to posteriorly, and when it is meeting to the posterior axillary line, there is a flaps point. It's called posterolateral, alveolar, and pleural point. So long artery is a combination of many artifacts. Essential to first identify the pleural points to pleural line, as most pathology about seats. The pleural line is a horizontal, hypoechoic. This is the pleural line, horizontal, more hypoechoic, situated between the two ribs, and giving it is a bat-like appearance. And these are the two rib shadow. Meaning give the bat sign. The long sliding sign. So respiration coil sliding on the visceral over the parietal pleura. So in the 2D mode, there is, if we change to and fro motion of the pleura, here is a muscle, here is the skin. So this is the sliding sign. And if we change to M mode, then we can get the seesaw sign. That is the C is the pleura, and there is sand below the structures. Then stratosphere sign, the absent long sliding gives rise to stratosphere sign, also called parapet sign. Those sensitivities not specific for pneumothorax can also be seen in the inflammatory or chronic adherence cases, fibrosis, atlectic spaces, and ARDS cases. Now coming to A lines, main horizontal artifact, repetition of the pleural line, and can also in the pneumothorax. These are the A line below the pleural lines. Now coming to long point, when there is a profile and there is absence of long sliding, then we look for the long point. So in putting in the M mode, the in between the seesaw sign and shutter sign, we get the long point. There is a seesaw sign, normal, long is sliding here, pleural line, but in the stratosphere, we cannot. There's no long sliding. So in between that, this point is called, in between that is called long point. This is a characteristic of pneumothorax. Coming to V lines, these are main vertical artifacts, also called long rockets. Normally, it's 2 to 3 lines between two ribs. If more than 2, it's called ground class rockets. Mechanism is interstitial edema first appear in the subpleural interlobular septa, which are surrounded by the alveolar gas. Then ultrasound beams entering this small pleural line fluid air system and reflected again and again and being trapped. So to and fro movements generating a long vertical hyperechoic artifact. So the V lines actually erase all the A lines. So ruling out the pneumothorax, and V lines are hyperechoic, narrow, and span across the image from pleura to base of the image. You can find. So what is interstitial syndrome? The pattern of diffuse presence of 3 or more V lines in the long field is in the anteromedial lateral long field is the interstitial syndrome. But we can find that posterior basal level due to gravitational accumulation of the fluid. So most commonly occur in the pulmonary edema, also can also in left heart failure or ARDS cases also. But the severity of the disease depends on the severe number of the B lines. And if there is more than 10 per screen, or there is in between the lines there is 3 millimeter apart, then it is a favor the diagnosis of ARDS. And B lines widely separated from each other, more than 7 mm, suggestive of fibrosis. And B lines can also occur in the multifocal pneumonia, but there we can take help from the thread sign to differentiate from the pulmonary edema. And what is C line? The C lines is caused by the adjacent consolidated tissue. Here is the C line. So it is nothing that from the consolidated long tissue. So there is a non-erected long tissue. The beam is traversed easily by the ultrasound beam. So it's looking like a liver tissue. So it's called hepatization of the lung. Tissue side here we can find that from the pleura, it is hardly any pleural effusion, but there is similar ecotexture with the spleen. Here is the spleen. The lung here is just looking like a spleen. So it is called tissue sign. Now coming to thread sign. Thread sign is the characteristic of pneumonia. Actually, here this is pleural effusion. There's an anechoic area. Below that, we can get the sharp line interrupted with the threaded non-sharp line, which is the air bronchogram. So this is called the thread sign. So in this concentrated lung, you can find reflection of the ultrasound beams in the air-filled bronchi surrounded by concentrated tissue. It's called air bronchogram. You can here to find the air bronchogram. And here is the already discussed thread sign. You can find the thread sign. Appears when the border of the aerated lungs and concentrated lungs is not sharp. So thread sign, tissue sign is translobar to the continuous consolidation, translobar consolidation. For the thread is non-translobar consolidation. Coming to pleural effusion first appears at the flaps point, usually hypoechoic to anechoic, but there are some particles there which is hyperechoic. And effusion in combination with the concentrated lung tissue suggestive of pneumonia. And in pleural effusion, there we can find the quad sign. That is the visceral pleura, then it's a parietal pleura and visceral pleura. And it is in these are two rib shadow. So this is a quadrangular area is called quad sign. But here we can see there is cometal artifact is there. So the lung is totally aerated. So there is no concentration here. So it is a pure pleural effusion. Now, if there is a multiple triangular hypoechoic and pleural based parenchymal lesion with a localized and or basal effusion, that's suggestive of pulmonary infection associated with pulmonary thromboembolism. Better predicts the peripheral pulmonary thromboembolism rather than the central one. Now coming to something related to blue and false protocols. Blue is bedside long ultrasound in emergency. False is fluid admission limited by long ultrasonography. Blue protocol is immediate diagnosis of the acute respiratory failure, and the false is the management in the circulatory failure. So there is various profile like A profile, ADS profile. DAS means there is without long sliding. So A profile is the normal, here presence of the long sliding, and DAS is the A profile without long sliding, the suspicion of pneumothorax. And B profile, anterior long sliding, long rockets can be seen in the pulmonary edema case. BDS is the without long sliding. It can be in the pneumonia. C profile is the anterior long constriction as defined by the thread sign, tissue sign, also suggestive of pneumonia. And AB profile is the half A and half B, also suggestive of pneumonia. So if a patient came, we go to the blue protocols. We search for the upper and lower blue points, and we search for the long sliding. And if long sliding is present, then there can be A profile or B profile. If it is B profile is there, then it is pulmonary edema. And if it is A profile is there, then we search for the DVT scan. And in DVT, if there is thrombosphere, then it is due to the pulmonary embolism. And it is free, and there is no DVT. And then we go to the flaps point. Here we go to the blue point, here is the flaps point. In flaps point, if there is finding, then it is pneumonia. If it is nothing, it's called COPD or it can be asthma. And if it's long standing is there is no long standing is abolished. So absence of long standing leads to ADS and BDS profile. BDS profile leading to pneumonia. ADS profile, here we can search for the long point. If it's a long point is present in the ADS profile, then it's a sure shot pneumothorax. And and if it's not without a long point, then we go for the other diagnostic modalities. Coming to false protocol, the concept is the A line transforms to B line at the pulmonary capillary wedge pressure than 18, and pulmonary edema generates a thickening of the inguinal septa, of which their subpleural and end is accessible with the for the lung ultrasound. So coming to false protocol, first ruling out the obstetric shock by simple cardiac sonography by looking for the pedal tamponade or RV dilation. Then we can have true protocol to rule out the pneumothorax by looking to the ADS profile. Then we're ruling out the cardiogenic shock from the B profile, ruling out the pulmonary edema. Then the next is the hypogenic shock. Hypogenic shock by ruling out by giving the correction of the fluid and giving correction of the parameter of the shock. Then it's ruled out. Then we suspect the shock. That's the distributic shock, most probably septic shock. So here fluid therapy after fluid therapy is not improving, so generating the B profile. Here we can restrict the fluid. When the distributed shock, when the ultrasound examination findings are A profile to B profile, then we must iatrogenic, there is iatrogenic pulmonary edema, so fluid should be discontinued. Now coming to the third part, the fast and e-fast. First is focus assessments on trauma. E-fast is the extended one. These are the terms used mainly in the trauma. So indication is mostly in the blunt trauma cases, penetrating heart trauma, closed heart trauma, or closed abdominal trauma, chest trauma, pneumothorax, or any caused by the hypertension. So examination of the abdominal structure by the carbon probe to 5 hours. Cardiac probe can be used. This is the point of the marker. Right upper quadrant in the Morrison's pouch, left quadrant sphenorenal space. Here is the subgyphoid or pericardial view, and is the pelvic view. So in the right upper quadrant, you can have that hepatorenal pouch, Morrison's pouch. You can see the blood, any blood here in the recess as a hypoechoic area. And similarly, in the left upper quadrant, sphenoidal abscess, you can specifically found the blood if there is splenic injury. The pelvic scan, there is free fluid and the just lateral to the bladder, or we can have the blood also as a hypoechoic area just below the bladder. Here we can over the abdomen, you can see the ascites. In the subgyphoid, we can know the heart structures. In the E-fast, the extended is the 2, 3, and 6, 5. Mainly the anterior and the lateral thorax. And in the anterior, we mainly look for the ruling out the pneumothorax, and the 2 and 5 we can mainly rule out the hemothorax. So in abdominal trauma, if the patient is unstable, we can do immediately fast, and if fast is positive, then directly shifting the patient to the operating room, and fast is negative, we can do a CT. In our patient, fast positive, we do a CT, and if fast is negative, we can stop the resuscitation and repeat the fast scan, or we can observe the patient depending on the clinical picture. Thank you.
Thank you, sir. Next, I would like to welcome for the final class, Dr. Samir Samal, sir. Sir will be taking regarding pulmonary artery catheter and its applications in ICU. Over to you, sir.
Hello everyone. Is it audible and my screen visible?
Yes, sir.
Okay. So finally we have come to the end of this 4 weeks classes. This is the last class. Actually, I'll be taking only radiology. I don't have BSc pulmonary catheter waveforms with me, so I'll only go with radiology today. It's already late anyhow. I'll try finishing very fast. Okay. So starting. So this is a G3P1, 28-year-old, second stage of labor, forceps delivery, PPH, multiple blood products. She eventually required ligation of both internal iliac artery. So what is the cause of this X-ray? Such an X-ray?
Tacho, trolley, fluid overload.
Okay, very good. And
ARDS.
ARDS, very good. And
Acute cardiogenic pulmonary edema.
very good. Okay, and every possible causes of bilateral diffusion filtered still. Don't stay limited to this case. Here we know it is trally only mostly, either trally or fluid overload. But what other things can also cause this? Whenever this question is asked, after saying first two answers, broaden your or tell more answers. Aspiration pneumonitis can also cause it. Okay. Okay.
Yes, sir.
Why there are chances of aspiration bilateral here in this question? Generally, it should be right. Whenever a question is given to you, after knowing the primary diagnosis, see for any other abnormality also. Any other abnormalities do you see? It's related to the tube, ET tube. Where is the carina? Mostly the carina. ET tube is ending here very high up. ET tube, okay, not properly present. Okay. Then yes, primary diagnosis have done all very good. Now 22-year-old Korean exchange student, febrile illness and respiratory distress. Diagnosis.
Miliary.
Miliary tuberculosis.
Very good, excellent answer. So the CT scan was this. Okay. Confirming what other do you find in this?
Multiple splenic infarcts are there.
Yeah.
Bilateral effusion, more on the right side as compared to left.
Okay. Yes. Very good. Very good. This one we have done in the neuro class, if you all remember. Okay. C234. Got it? Remember? And this black is your
Disc intervertebral.
disc protrusion. Okay. It is present at two levels. Here, very major. Here, minor. Okay, these places. Here, there is fused vertebrae. Okay, this one we are done. So fever, diarrhea, vomiting, right upper quadrant, pain, trip to South Asia, fever. So differential diagnosis.
Abscess.
Maybe clear.
Liver
Very good.
abscess.
Which abscess?
Possibility of amoebic liver abscess.
Yes, liver abscess. Very good. Okay. Who causes amoebic liver abscess? Which organism?
Anti-ambassador.
Very good. Entamoeba histolytica. Okay, very good answer. What else do you see in this? What can be other causes of liver abscess?
Klebsiella pneumoniae.
And what other diagnosis can be?
Melioidosis.
Yes, very good, very good. Which organism?
Burkholderia. Pseudomyelitis.
Pseudomyelitis.
Very good. Why did you suspect?
Abscess is there in the liver as well as in the spleen.
Yeah, very good. Okay, multiple liver abscess are there in the spleen also. Okay, so here liver abscess, although very rare in melioidosis as huge abscesses, generally it is micro abscesses, septic embolytics. But here we see your spleen is also involved. So, okay, and any other organism that can cause liver abscess? Not bacterial. Fungal. Candida can also cause, okay? Fungal infection, okay? Candida can cause liver abscess. So this is your, this one also we had discussed, road traffic accident, whiplash injury. Neuro, this one also we have discussed. The icy bleed, midline shift, edema, loss of gray white differentiation. This one also we have seen. Okay. Now this one. Why is it difficult to ventilate this patient?
Left-sided pneumothorax.
Very good. Okay. So left-sided pneumothorax. It is anterior, posterior. Where is it? Where do you suspect this to be?
Anterior.
Anterior. Okay. It is a supine X-ray. So mostly in the front, it is an anterior pneumothorax. Very good. This one. Again, why this patient is difficult to ventilate?
Pneumo. Left side.
Left-sided
Right.
pneumothorax.
And
Along
right.
with transcutaneous pacer is there, maybe due to arrhythmias in shock patient.
Yes. Patient is already on tracheostomy. Okay. Visible. Patient is tracheostomized, patient has pacemaker, patient has sternal wires, so maybe his operated case, he already has drain, but see right side also sulcus sign is present, okay? So it is bilateral pneumothorax. Okay? Left side also pneumothorax is present, right side also pneumothorax is present. Okay? What is this thing?
Pad.
Transcutaneous pacing pad.
Yeah, very good. Here, what is this patient having?
Pneumo.
Mechanical assist devices. LVAD.
What is LVAD?
Left ventricular. Left ventricular assist device.
So here only left is getting assisted.
BiVAD is.
Yeah, it's a byword. Okay, by both the ventricles are getting assisted, so it's a byword. Okay, so very good, good answer. Then indications.
Refractory cardiogenic shock,
Okay,
mechanical complications following cardiac myocardial infarction, ventricular rupture,
and
re,
and
prevalve rupture,
Failure as a bridge to transplant.
bridge to transplant. Very good, very good. Okay, myocarditis also, viral myocarditis. And there is a pleural effusion. Okay, this one very simple.
Bronchiectasis,
Bronchiectasis. Very good. Causes
tuberculosis,
tuberculosis,
and
cystic fibrosis,
very good. And
mm,
Cartag-
yes,
Cartagena syndrome,
yes, carcinogenesis syndrome. Very good. And keep on telling causes. Carbon dilatation, aspiration, toxic gas inhalation, necrotizing pneumonia. Okay, this one we had done. Whenever a elderly man comes with confused combative, generally look for hydrocephalus. Okay, so here there is hydrocephalus ex vacui. Okay, this one we had done already previously. This one also we have done. Cerebral edema, CSF tapping to be avoided. Okay, now tell this one. What abnormality do you see here?
necrotitis with the peripancreatic collection,
What is this?
calcification over the pancreas,
Calcification of pancreas. So calcified means mostly it is a chronic pancreatitis. Okay. Then where is the perinephritis? Which what did you tell? Collection. Where is the collection? There is no collection here.
no collection.
What is this?
fat stranding,
Yeah, mesenteric fraction. Very good. What is this?
Ulcerative,
Perihepatic collection.
Perihepatic
ulcer-
collection. Very good. This is your liver. This is perihepatic collection. Very good. So this is your pancreas. There are calcifications present means mostly it is a chronic pancreatitis. Okay. Chronic calcific pancreatitis. Now it has come with acute on chronic. This is your fat standing. This is your perihepatic collection. Very good. Very good answer. This one.
dextrocardia,
Dextrocardia.
How do you know the film is not reversed?
left side is a
labeled,
labeled,
Yeah, left side is labeled. That is why we are. What other clues we can get?
liver,
What other hints?
Gastric
Suppose your
bubble.
yeah, very good. Suppose your gastric bubble is this side. So how do you? What can be the causes?
cytosinosis,
versus
Film is
Cytosinosis totally. But how to then confirm whether it is a wrongly put mark of left? Suppose your cardiac side is this
ECG,
side, your gastric bubble is also present this side, and suppose this is not marked. How to confirm?
by doing
bedside
ECG.
echo can be done, ECG can be done,
ECG or
bedside echo,
Echo.
echo, transference echo. Okay, very good. So to confirm, we have to do transference echo. Very good. Why? Tell this is a chest X-ray of a fractured neck of femur, old age patient. Patient needs ICU backup post-op. So tell me the various causes that you think that the patient will need ICU backup. Various reason.
Permanent pacemaker in situ. There is a diaphragmatic elevation on the left side, maybe phrenic nerve palsy. That's why there may be the difficulty in ventilation.
Very good. And
Hyperinflated lungs.
yes, inflated
Lungs
lungs.
are
Very good.
inflated.
Okay.
Flattening of diaphragm on the right side, maybe chronic pathology, chronic lung pathology.
Yes, very good. Then which physiological means when can you get flattening of diaphragm?
In COPD, hyperemphysematous lung.
Physiology I told.
Physio-
Inspiratory film. Okay. Inspiratory film you can get a flattened diaphragm. Okay. Any other cause? There are few things here. Is it visible to you? It is actually very difficult to visualize.
Widening
External
of
valves are present. Okay. So patient is a CABG patient, or there are no valves, artificial valves seen unless it is a bioprosthetic valve. So mostly cardiac surgery because of CABG. So there are chances of failure. Your cardiac shadow is also enlarged. Okay, covering more than half. So there is a chances of left ventricular failure and enlargement. Okay, fine. This one very easy. Patient posted for surgery, you need ICU backup or SDU backup. Why?
Looks
This one
hyperinflated tubular heart. COPD looks like COPD lung.
COPD lung. Excellent. Very good. Okay. Hyperlucent fields. Hyperlucent fields, very less bronchovascular markings. COPD. Very good. This one, severe abdominal pain. Past history of chronic atrial fibrillation, hypertension, hypercholesterolemia. So what all are present?
pancreatitis due to hypertriglyceridemia.
Where is triglycerides? Triglycerides. Okay. Can be a differential. Anything else?
Chronic atrial fibrillation with severe abdominal pain, maybe mesenteric ischemia.
Yes, very good. So this is mostly could be a mesenteric ischemia. So what all findings are present?
Non-enhancement.
This is what a cut section film of what? First start your answer like that. Plain CT abdomen or CCT abdomen section at the level of what? First answer those.
CCT abdomen axial section.
Yes, CCT abdomen.
Cut at the level of
Okay. So what are the findings here? What are the findings? What is this black? What does black indicate?
this,
Air in the intestinal wall. Pneumatosis intestinalis.
Where is that finding? Can you tell?
in the center, the bowel, 3 air pockets.
These or this? Which one you're telling?
No, sir. Upper one. Three, yes.
This.
That. Hmm.
Okay.
And the one above, seen above the vertebra also.
This one.
Yes.
Okay. And
Few areas are enhancing, few areas of the bowel are non-enhancing
why?
because of absence of circulation, central ischemia.
Okay. What is this area?
Pneumoperitoneum, sir.
Yes, pneumoperitoneum. So that means there is a
Maybe
Neuro-
perforation.
perforation. Very good. And what is this? Again, contrast is outside in the peritoneum. Okay.
Con-
This and this.
Contrast
Okay.
extravasation.
Yeah, extravasation. So there is definitely a perforation. What here? This one. What is the problem? There is contrast, but the walls are thickened. Is it visible?
Yes, sir.
Visible, sir.
Yeah. So there is thickened bowel. Okay. Then there is your again your mesenteric fat standing. Okay. Very good. Very good answers. This one, patient dyspnea and repeated intubation. What is the cause?
Right main bronchus intubation, left sided pleural effusion.
Mhm.
This is your terrain, right? Or
Okay.
not? This is your left bronchus, right bronchus. Tube ends here. So it is square. Okay. So not
Okay.
that. Still. And also it is inflated both sides. No. So unlikely that this is only going into the right side. This lung is also inflated, isn't it?
Hmm.
If it will be only
Yes.
single side ventilation, this lung collapse will be present. So both
Yes.
lungs are getting ventilated. But you again see the question. Patient presented with dyspnea was intubated for dyspnea. What is the cause of dyspnea?
upper airway obstruction question.
Uh-huh.
Upper airway obstruction,
What upper airway?
stridor, laryngeal edema.
Laryngeal edema. Then why am I showing the X-ray for laryngeal edema?
Tracheal malacia, tracheal collapse.
Maybe esophageal intubation.
No. Again, dyspnea. Prior to intubation, there was dyspnea. What do you think is this? Is there any widening?
Thyroid mass
Media
compression.
channel widening.
Yeah. Okay. So what is this mostly?
Any
Retrosternal,
thyroid
Here
mass,
also.
mediastinal mass.
This one also
retrosternal extension of the thyroid.
of thyroid. Very good. Okay. The dyspnea was present prior. Okay. So that is the hint. Lungs filled more or less sleeping normal. Left sidal pleural effusion, not sure, cannot tell. You see the surface is visible. Okay. So mostly more or less normal lungs. Patient had dyspnea prior to intubation. So that is why. So mostly there is a upper airway obstruction. So look for the mediastinum. Okay. So huge mediastinal widening is present. This one, cardiac surgery today. IABP is present. So is it proper place, and what phase of cardiac cycle was the film taken?
It is a tip seen in the second intercostal space. It should be ideally below the origin of left subclavian artery.
Yes. So this
Balloon is not seen. It is
Balloon is not inflated. It is the systolic phase of the
systolic phase. Very good. So here is our balloon. Okay. So it is not inflated. So the systolic phase. Very good. And where it should be?
2 centimeter below the origin of the subclavian vein. Subclavian artery.
High up. Okay. Generally, it should be present in second or third intercostal space. Okay. Just above the left main bronchus. Okay. So it should be around here, in this place. Here we are seeing immediately in the first, just below the clavicle. Okay. High up, and mostly this taken in the systolic phase. So we need to reposition it. Very good.
Sir, where
This
we
one?
have to look for the balloon position? Usually, sir.
This is the balloon, no? This one.
Okay, there
It is deflated.
Okay.
Or my cursor is visible?
Yes, sir.
Yeah, this is the balloon. Okay. Got it?
Okay, sir.
So this will be inflated. Your white ear will be little broader. Okay. Here we can see some air. Understood? If it is inflated. Understood?
Okay, sir.
Left paravertebral region.
Yeah, left paravertebral region. Very good. Okay. So this one. So like sometimes you mark, suppose ET tube, your very high insufflant is there. You see this is the ET tube cuff. Is it visible? Black here?
Yes, sir.
Visible, no?
Yes, sir.
Yeah. So like that here, if balloon inflation will be there, you can know if there is balloon inflation. This is completely collapsed balloon. Okay. This one.
Intestinal obstruction.
Ogilvy.
And
Multiple air fluid levels, sir.
okay.
Thumb sign.
No. See the loops properly. This is the loop. Okay. What is this? This air is inside or outside? This air outside. Okay. Here also loops are there. This air is outside. So what does that mean? Air outside.
Perforation.
Yeah.
Perforation is.
Okay. So this is called Riegler's sign or the double wall sign. Okay. What procedure has been done in this patient? Where is the abnormality?
Transverse and descending colon has been resected.
Why do you say so?
IVC filter.
IVC filter. Very good. Excellent answer. Okay. Visible? Everybody visible? Okay. So this is IVC filter. So what is the need? Means when is it done?
DVT with pulmonary embolism and there is contraindication to anticoagulation.
Very good. Comment on the tubes and lines. What all tubes do you see? What all can you see? Okay, tell me what is this?
Is it ICD, sir?
This is a
Is looks like ICD, sir.
ICD. Huh?
It looks like ICD, sir.
Yeah, ICD. Then ET tube. Comment on the ET tube. It is ending just at the level of carina. Okay, maybe you can withdraw. So these are the sternal wires. Now tell me what is this?
Transjugular
Pacemaker.
pacemaking.
Huh?
Is the pacemaker wire, sir?
PA catheter.
Yes, PA catheter. Why pacemaker? Why did you tell pacemaker? Where is it ending? See, this is the catheter which has come here and come here also. So what is this? Going into the IVC by mistake. Okay. Okay. Then
Hmm.
from IVC, it has gone into the right atrium and then here. What is here? Where is it lying? PSC, pulmonary artery. Okay. Understood?
Yes, sir.
There is a problem with the pulmonary artery. Is it visible? Pulmonary artery catheter.
Yes, sir.
Okay. Then there are sternal wires. So mostly a post-op cardiac patient. This is the drain. Okay. So this patient had a debridement procedure due to deep sternal wound infection, complicating the cardiac surgery. So what are the risk factors for sternal dehiscence? What are the risk factors? What are the risk factors for patient?
Bilateral inhomogeneous opacities in bilateral lung field with both CP angle blunted may be possibility of sepsis, septic shock,
Okay.
ARDS.
Not much of ARDS. Not much of ARDS. Wound dehiscence. Tell me the causes of wound dehiscence.
Poor glycemic control.
So diabetes and septic shock is also okay. That can cause wound dehiscence. Other factors are, remember, obesity, okay, immunosuppression, excessive coughing, prolonged surgery, massive bleeding. These are the various causes that can cause your wound dehiscence, and also if there is internal mammary graft that comes about. These findings, that purple ellipses, that is mostly because of asbestos exposure. Okay, it's very difficult to catch, so it doesn't matter. Don't worry. This one, after 1 hour of tracheostomy, this was done.
Left-sided pneumothorax.
Pneumothorax. Okay, and
Pneumomediastinum.
pneumomediastinum. Okay, and very good. And
Collapse of the left. Collapsed lung.
why is the collapse, lung collapse present? because of pneumo, no?
Blood secretions.
Pneumonia.
And where air is present?
Subcutaneous
Black, black.
Deep sulfur.
Pneumothorax, pneumopericardium, and pneumomediastinum.
And
Subcutaneous, sir.
Subcutaneous emphysema.
subcutaneous emphysema. This one, okay? So this is subcutaneous emphysema. Pneumomediastinum. So what can cause this? Percutaneous tracheostomy. Generally, we get only pneumothorax. Suppose if you go into the pleura, but why this subcut and pneumomediastinum? Why is that at present?
Along the bronchial sheath, they are spreading.
So how does that spread? Which injury? Where? Generally, there is a tracheal perforation. Okay. If there is pneumomediastinum is present, then mostly it is because of direct injury to the trachea. Okay. So very good answers. Then this one, hemoptysis, respiratory failure, acute renal failure. Excellent answer.
Vaginal granulomatosis.
Very good. And
Good posture.
Good posture.
Very good. And
Diffuse annular hemorrhage.
yes. And any other cause? All immunological causes.
Other pulmorenal syndromes. Like
And
anywhere, any ANCA positive vasculitis.
any?
Sir, any ANCA positive vasculitis cause.
Yeah, something like that. What is that? Antiphospholipid. Okay. Vasculitis. Your polyarteritis nodosa can also cause. Okay. Or your catastrophic antiphospholipid antibody syndrome can also cause. Okay. This one.
Right main bronchus obstruction. DDs are right whole lung collapse because of right main bronchus obstruction.
Very good. Why do you tell it is a right bronchus obstruction?
Deviation of trachea to the right side.
Because of collapsed.
It's to the same side of collapse.
Same
Very
side
good.
of deviation.
Then there is the cutoff, right there, cutoff. Okay. If it would have been only an effusion, there could have been air, could have been seen maybe the right bronchus, main bronchus, but here is the direct. So here is a mass compressing the right main bronchus. Okay. And what are these?
Coin shape, coin shape.
Yes.
Pulmonary nodules, lymphadenopathy.
No, the metastasis, because here is a CA bronchus with CA, mostly CA lung or CA bronchus, CA here compressing the bronchus. So these are all your lung meds. Okay.
Cannonball section.
One, yeah, 1, 2. Where do we see cannonball meds? Which disease? In which disease do we see cannonball metastasis to the lungs?
Aspergillosis.
No, I said metastasis. Cannonball metastasis to the lungs.
From breast or prostate.
Yeah, your prostate or your germ cell tumors. Okay. Seminomas. Okay. So, what is the procedure done here? And what complication patient is having?
Valve replacement. It's Valve
Valve replacement.
like aorta. Mitral.
What surgery the patient has undergone?
Valve replacement surgery.
Which valve?
Mitral.
Okay.
Mitral and
Both valves.
both
Both.
aortic will also replace.
Aortic
Which
plus
one is
mitral.
aortic? Which one is mitral?
The above one is the aortic, below one is the mitral. The
Suppose there is a
circular one is
single
mitral.
valve. Yeah, okay. Upper one is aortic, lower one is mitral. Suppose there is a single valve. How do you know whether it is aortic or mitral?
Usually draw a line from the right CP angle to the if the
What is CP angle? Don't say CP angle.
sir,
What is CP angle? Costophrenic.
uh,
Huh?
cardiophrenic, sir.
So tell the full line. Okay, don't say partial.
From the right cardiophrenic angle to
Cardiophrenic.
left.
From right cardiophrenic angle to
Sir, left side.
where? Here, here.
No, sir, just below the aortic knuckle there.
Yeah.
I don't know the exact point where to
So
say.
basically, at that line, okay.
If the ring is having
Nearer
above
to
that
that
line,
line, it is the aortic valve. Okay.
yes, sir.
Which lobes are affected? Pneumonia.
Right lower,
Only lower.
right middle and the lower, sir.
Middle lobe. Why middle? Why do you think there is a middle lobe is also affected and not only the lower lobe?
Fissure.
What? Think? Tell.
So the horizontal fissure is seen.
So it will be seen in lower lobe also. Only lower lobe pneumonia also it will be seen or it will not be seen. Why do you say middle lobe is affected? What structure is not visible here that leads us to say that it is the middle lobe pneumonia is also present along with lower lobe pneumonia. So for lower lobe pneumonia, we should see if there is obstruction of the diaphragm. That means it is a lower lobe pneumonia. Your right heart body is not visible. That means it is a middle lobe pneumonia. Understood? There has to be obstruction of right middle lobe to tell that it is a middle lobe pneumonia. This one.
Right upper lobe
Right
collapse.
upper lobe collapse.
Why right upper lobe collapse? Right upper lobe is definitely involved. Why did you tell collapse? Patient has fever. Why not pneumonia? New fever, new productive cough. Why not pneumonia? Can be pneumonia also. Okay.
Can be pneumonia also, sir. Trachea is
Pneumonia.
not
Right
fully
upper lobe
visible.
pneumonia. So right upper lobe pneumonia. What are your common causes?
Tuberculosis.
Very good, tuberculosis. And upper lobe is involved in which diseases?
Sorry, sir.
Yes.
Sir, what was the question?
Upper lobe involvement in which other diseases?
Mycoplasma, sir.
Okay, generally carcinomas and also it is mostly upper lobe. Okay. What goes against carcinoma is acute presentation. This one, what do you think this is?
So some drug, he's smuggling drugs, so that
Yeah,
thing is seen
you can
inside
see
the
your
bottle.
toilet.
Yeah.
Okay. Yeah. So this is cocaine overdose leak that causes to sudden cardiac arrest. One, right hip pain, septic shock.
Muscular necrosis.
So right hip pain, orthopedics word, septic shock. So what do we search for? First we have to look at the right side. Okay.
Cause abscess.
Alright. Where? This one. Okay. Got it. Since there is a right side problem, you have to look main and the right side, compare with the left where the difference is. Any difference is present. So this is most okay hyperlucence present. So most common cause of infection, which organism?
Maybe TB, melioidosis.
Melioidosis, okay, organism. And abscess, which organism causes abscess?
Sorry, any anaerobes.
And most common first organism that we read in microbiology?
Staphylococcus
I'm
aureus.
positive.
Staphylococcus, okay. This one started on continuous renal replacement therapy, acute and chronic renal failure, hypertension and tachycardia. What is present? Why the cause of hypotension?
Pericardial effusion. Like a subcostal view, sir. Effusion, pericardial effusion.
Pericardial effusion, very good. So this is the pericardial effusion. Okay. So pericardial effusion, maybe that is the cause of hypertension. So what could be the causes of your pericardial effusion in this patient? Patient is a known case of chronic renal failure, acute and chronic.
Chronic
So what
chronic
can we
renal
do?
failure with fluid overload.
Fluid overload.
Chronic renal failure with fluid overload. Then anticoagulation used during CVV HDF.
So what can that cause? Hemorrhagic pericarditis. Okay. Then your
Hemorrhage.
CKD, yeah. So uremic pericarditis. Okay. On patient is CKD, if the patient has chances CKD could be on. There is maybe a patient of nephrotic syndrome or whatever renal causes hypoalbumin that can also cause. So identify the structures. Okay. So what is this one? This structure.
Right atrium, right ventricle.
Right
Below
atrium. Very good. This one.
right ventricle.
This one.
Left atrium.
Added LALV.
LALV. Okay. So this is thick walled mostly. So this is a left ventricular left
Hypoprof.
ventricle. Okay. So subcostal view. So this is your the direction of probe or rays coming from the flow from this side. So in the subcostal view, nearest to the subcostal is the right ventricle. That is also we get. So this is the right ventricle. This is the left ventricle. This is the right atrium. This is the left atrium. So this is your effusion, pericardial effusion. Got it, everyone? This is your pericardial effusion. Okay. This is your right atrium. This is your effusion. Okay. So 43-year-old lady Mechanically ventilated in the ICU for past 3 weeks because of GBS suddenly becomes hypotensive and tachycardic. SpO2 78, drowsy, echo shows this one.
Pulmonary embolism.
VIR is 4.9 per second. Estimated RAP is 10. So what can be the cause?
Dilated RV, pulmonary embolism. There is a D shape LV. Maybe
Very good. Very good. Very good. Excellent answer.
massive
Okay.
pulmonary embolism.
Massive pulmonary. Very good. So that's all. We leave. Thank you everyone for attending. So I hope you learned in this past few days. So we'll take your goodbye, good night. Okay. If you want any further classes or courses, we will plan accordingly and take. Okay.
Thank you, sir.
Okay, sir. Thank you. Thank you. Yes, sir.
So goodbye from us. This course is now over. So I hope you all learned as much as possible. Means whatever you thought of gaining, I hope you gained all that. If no, then please tell me in that group, or you can send me personally also, so that we will accordingly modify from next time. And if any also cases, okay.
Okay, sir. Thank you.
Thank you. Like everybody.